Live? Nicholas is live. Babhulkar sir, good evening.
Good evening, Dhaval.
Sir,
Well,
good evening, sir.
Hi, Antao. Good evening.
Thank you for and gracing the occasion.
Good.
Thank you, sir.
Good.
Dr. Zirkle, Bhai,
Yes,
how are you? Good?
I'm okay.
Hello, Nicholas. Good. I'm
Yes.
fine.
You're looking younger and younger.
Well, well, how old would you be if you didn't know how old you were?
That's a great thing.
Say hi to Jean.
Yeah,
Good morning.
Hi, Jean.
Hello, Jean.
I'm the technician today.
hello, Farouk.
Hello, Farouk. Hello,
Yeah.
Antao. Good to see you.
Good to
Thank
see you too. You're a technician from yesterday.
Yeah.
She's my IT consultant.
Yeah.
How did you get up? Did you keep the bed or you got up on your own?
I get up on my own. I went to bed really early to get up really early.
Lou usually wakes up at 4.
This is going to be a good discussion. I didn't realize it was all about sign.
Yes, only sign,
Oh, good.
nothing else.
We've done 350,000 cases now around the world.
Yeah. Tushar, when you are free, you can come. Yeah, it's going to start after about 10 minutes, 5 minutes. All right, you take your time, 5 minutes. Bye.
Thousand cases now around the world.
50,000 is quite a number.
Yeah. Tushar,
Yes,
when you are
yes.
free, you can come.
Yeah. Our database is working better, so we have good follow-up now.
About 10 minutes, 5 minutes.
Yes.
We're very happy.
All right.
about it.
so
Take your
the
time,
350,000 all have a pre-op and a post-op X-ray at least.
No,
All have pre-op, post-op, and
Yes.
50% have follow-up.
50% right.
Wow.
50,000 cases now around the world.
50,000 is quite a number.
Yeah. Tushar,
Yes,
when you are
yes.
free, you can come.
Yeah. Our database is working better, so we have good
And
follow-up
how is
now.
it that you're able to motivate
Yes.
We're very happy.
100%?
about it.
The 350,000 all have a pre-op and a post-op X-ray at least. The image.
No,
All have pre-op, post-op, and
Yes,
50% have follow-up.
50% right.
Wow.
1,000 cases now
Placements
around the world.
50,000 is quite a number.
Yeah.
That's the thing.
Tushar,
Yes,
when you are
yes.
free, you can come.
Yeah.
Unless
Our
you
database
come
is working better, so
Yes.
and we're going higher. It's really nice because we can get
Yes.
follow-up, and we really are innovating a lot of new nails, our new type of nail,
Yeah.
and using the plate more. We've designed a new plate. We've designed new reamers, which can take a lot of bone graft. So we're very happy how things are going. And our surgeons are really good.
And for fewer follow-ups, you'll get harder emails, harder mails.
He said the fewer follow-ups, the harder the emails.
Hello.
Hello.
Oh.
Okay, sir. Okay, sir.
Good afternoon, Kulkarni sir.
Good afternoon, Dhaval Saab. How are you?
All well, sir. All well. Good to see you.
Nice to see you again.
Thank you.
Sir, good afternoon.
Good afternoon. Hi, Antao. Nice
Hi.
to meet you here on phone.
Thank you, sir. Thank you for making time for the SIGN webinar.
टन्ना सरांना पण फोन करायला पाहिजे जॉईन व्हा म्हणून.
का?
त्यांनी सांगितलं टन्ना सरांना पण फोन करून सांगा जॉईन व्हायला.
He said he could.
Okay, we'll just, we're ready to help if you need it.
हा दिलीप त्यांनी आमचा फोन आलाय तू जॉईन हो म्हणून. हो बरं मी वेबिनार मध्ये रेडी हे तिथं ठेवता.
Sir, you started teaching them orthopedics from your laptop?
Antao, everything is ready?
Yeah. How many grandchildren, sir? How many grandchildren?
Grandchildren? Grandchildren are 6.
So,
and 1 grandchild.
oh, wow.
A very happy man.
Very, very.
Yeah.
It's a lifetime blessing to have grandchild.
Yeah, that's right. A few lucky persons have that.
Yes, exactly.
Navin, are we ready to kick off?
We're ready.
Shinde Saab, namaskar.
Namaste. Good evening, sir.
Good evening. Today you can't say I am the president of as you normally used to. Welcome, President of MOA.
Oh, hello.
You have here a lot of past presidents of the Indian Orthopaedic Association, presidents of the state organizations, a lot of people who have joined us because of your name and your mission. It speaks
Thank
for
you. I really appreciate.
Yeah,
Thank you. I'm very humble about that because it's all of us.
thank you.
Look at chat. There's something on chat.
For a humble man, humility is common. For a not so humble man, humility is never seen.
Oh, thank you. I appreciate all of you showing your sign surgery.
Yeah.
You know, you'll appreciate.
Farooq, how is Saeed doing?
Said is doing all right. Just
Good.
because of Corona, he's not going outside. He's healthy, but there are some sensation that is some neurological thing that is sensory only bothering him. Otherwise, he is all right.
You know?
And he can, his closure was good. He can pass stool.
Good. Yeah, that's great. Give him my regards.
Yeah, of course. He knows. And how are you doing? How is Sarah?
We're doing fine here. Just really busy trying to get digital education going like you're doing. And we have a hub which people can enter, and now we are adding more and more to it.
Yes,
and
more
we're
people
hoping
are-
the surgeons around the
more
world
activities in
will
the
add
hub.
to it. Yeah.
And are you going to office? Yesterday, it seems
No.
that you are in the office. Oh, no,
No,
here?
the machinists are in the office. Gene is there, but the majority of our workers have to stay home because of the pandemic.
That's good.
But we're still working and communicating.
We get fewer cases nowadays because of the pandemic.
Good.
Less traffic.
Yes, less traffic, but we're still seeing almost the same amount. Of, you're just seeing some hospitals increase and some decrease.
Because in many hospitals, normal activities were suspended because they have been made COVID hospitals entirely.
Yeah.
Goindra, how are you?
Hello, how are you?
Dr. Tanna sir has joined or not joined still?
He is yet to come.
He is yet to come.
Yeah, I phoned him just now. He said another few minutes I will be there.
Okay, okay. So then we can start, I think.
Good evening,
Yeah, you can start.
Or we can wait for 1 or 2 minutes.
Good evening, sir.
Namaskar.
Good evening.
Hi,
Jawahar bhai.
All fine.
Nice to see your smiling face.
Thank you.
Hi, Jawar.
All fine, sir. How are you?
First class.
Very good. Very good.
So I think 13 has joined already. Now only 2 are remaining. Who 2 are remaining? We were 15. We were 15. Kamlesh has not joined. 14. The 15th who is remaining?
Tanna sir.
1, 2, 3. Okay. Dr. Tanna sir is only remaining.
Yeah.
So should I start with the introduction? So that will be in the right time because the people are waiting.
Yeah.
Yes.
So with your permission, I am just starting the introduction. And we are really very much thankful to all the faculty and particularly Dr. Antao sir for coordinating all these, moderating everything with Dr. Zirkle sir. We are very much happy that Innovator and the Humanitarian award winner Dr. Zirkle sir is here with us. And for the viewers, just click the recordings and you can see the previous webinars. And if you want to know about our chief guest faculty, Dr. Zirkle sir, is from USA, Richland. Just click this link. You will get the complete his details on the website. Okay. And we have now today other 5 faculties from different regions. Dr. Ramesh Singh has joined or not? Dr. Ramesh Singh has joined?
Yes, I am here, sir.
Okay, sir. Okay, sir. I was not able to see. Okay, welcome to all. And for the viewers, just click this link here, red button here, and you will be seeing the whole webinar here. And for the questions, just click here and click the send button. We'll get the questions and we'll put the question to the faculty. And some of the device, there is an ask button. Then click the ask button and question will come. And those who are seeing with the very small device, they can record their audio or video in a WhatsApp and just click WhatsApp to Dr. Navin Thakkar and I will get that message and I will pass on to moderator and the relevant question to faculty. Dr. Louis Zirkle is our guest faculty and Dr. Antao sir will give a detailed introduction of him, complete profile. Dr. Antao sir is our moderator. Dr. D Tanna sir is joining with us within a minute. Dr. G S Kulkarni sir has joined. Welcome, sir. Dr. Sudhir Babhulkar sir, he has also some experience of operated a sign nail. We have other faculties which in detail will be introduced by Dr. Dhavalbhai, Dr. Ramesh Singh from Kathmandu, Nepal, Dr. Truffaut from the Cambodia, Dr. Joseph
Yes.
from the Tanzania, and we have Dr. Yu from Vietnam, and we have Dr. Mahmood Farooqi from the Bangladesh, and our own President of Maharashtra Orthopaedic Association, Dr. Ajit Sinde sir. He is also going to share his experience of these innovative nails. Dr. Jawar Jetwa is an innovator, and he is our past president of Gujarat Orthopaedic Association. And Dr. Dhavalbhai is here. He is immediate past president of Gujarat Orthopaedic Association. And Kamlesh Bhai probably has not joined. He will join shortly. So Dhavalbhai, you can give a small introduction on, and can hand over to Dr. Antao. Then I will start the PowerPoint presentation of what you have sent to me.
Sure, Navin bhai,
Okay.
thank you so much. Welcome everybody, respected senior Dr. Babhulkar sir, Dr. Tanna sir, and GSK sir, and Dr. Antao, and Dr. Zirkle. It's a great pleasure to invite colleagues from AO Alliance who have been working with the SIGN project in their respective countries with some great efforts and great results. Notable among which is Dr. Ramesh Singh from Kathmandu. He is the Dean of the Kathmandu Medical College and he heads the AO Alliance for the Asian region currently. And he's been a friend for 10 years and he's been the leading force in the AO Alliance over here. Dr. Pot from Cambodia is another good friend. Met him twice in Cambodia and seen the work, especially with the SIGN nails. He also runs the fellowship program for the AO Alliance.
Thank you.
Then we have my good friend, Dr. Hugh from Vietnam, a young surgeon with the dynamic researcher, currently in Taiwan doing research. Welcome, Dr. Hugh. And then we have Dr. Farooq from Bangladesh, whom I met last year in the faculty education program. And he again is a great contributor to SIGN program from Bangladesh, along with his other colleagues. And last but not the least is Joseph from far off from Tanzania. But he's like the very fast bowler. He's the one who has a huge experience of polytrauma, especially femoral shaft fractures. And it would be fantastic to hear from him about the SIGN experience. So welcome, Joseph. And now I would request Dr. Antao sir to then introduce our distinguished guest, Dr. Zirkle, whose idea, philosophy works in many countries and changes many lives. Dr. Antao. Thank you.
Okay.
Sir, your voice, little mic should be nearer to your mouth. Antao sir.
Can you hear me?
Yes.
Yeah, now it is coming. Right.
Can I play my presentation or?
You want to play your presentation? That slides have been here, I think. Your sequence. You want to play from your side?
Huh?
Okay. Start from your side. Automatically, my screen will go. No issue, sir. But keep your mic near your collar so that everybody you are audible very well. That yes, your corded mic, sir. Cord.
Okay.
Earphone. Your earphone.
Yeah, right.
Hello.
Yeah.
That keep nearer. Yeah.
Can you hear me now?
Yes, yeah, we can hear you. Or speak little louder. And are you sharing the screen? Then start sharing, so that we will not lose the time. Green button at 6 o'clock. Share the screen and select the screen where we all are seen, and then open up your PowerPoint. These are just introduction slides, sir. If you, okay, fine. Yeah, it's coming. Now your screen is coming. But probably if internet connection will be slow, it will take time. No, it's coming very well. You can open up the PowerPoint, your PowerPoint. Yeah. Whatever final PowerPoint you are having. Final version, sir.
It's in now?
Yeah. make it a
bigger.
yes. So yeah, fantastic, sir. It is all well. Just speak little louder so that your mic is not near to your mouth. That is the only issue. And be in front of the camera so everybody can see you. Yes. Start, please.
On behalf of the SIGN family, I would like to thank the Gujarat Orthopaedic Association for giving us this platform and arranging this webinar. And mostly I must thank my friends Dr. Navin Bhai and Babhulkar who made it my dream to come true.
Thank you, sir.
Friends, welcome for this webinar. We have among us here legends like Dr. D Tanna, whose book Dr. Zirkle will remember, Interlocking Nail. I had gifted him to when he was in India. And then we have the emperors and kings of trauma like Dr. Kulkarni sir, Babhulkar sir, and the all eminent faculty that is here.
Just click on the screen, then you will be able to advance the slide.
All right.
Okay.
One will wonder where did I meet Dr. Zirkle? To complete the circle that the Gujarat Orthopaedic Association has started this webinar.
Yes.
I met Dr. Zirkle in Gujarat, Ahmedabad.
Ayokon, yes.
Conference. And to tell you the story short story behind it, I was the Arthroscopy Society secretary, and I had given my presentation on meniscus tears, and I saw Englishman, fair man sitting in the audience. And when I finished my presentation, I came down and I sat near Dr. Sanjay Trivedi, Ahmedabad arthroscopist, and I said, who is this white man Englishman trying to listen to our lectures? Are, you said you don't know him? He is Dr. Zirkle. I said, who is Zirkle? Zirkle is the person who came to help us in this when there was Mehsana was shaken by earthquake, and that's how the sign nail came to my knowledge. And I went and say hello to Dr. Zirkle, and Dr. Zirkle was kind enough to come out of the hall, and we had an exchange. And then he sort of thought I would be a nice right person to start the sign program, and that's how we started in Holy Spirit. What is then the sign nail? Sign nail is a construct, solid nail construct with Herzog bang of 9 degrees, proximal end, static hole and dynamic hole. In the up part and down part also we have 2 dynamic hole. So 3 oval shots which are important for dynamization. And this is the fin nail. If you see this here, this is the sign nail with 2 oval shots and 1 static and 1 oval here with sign screws. And this is the fin nail, which has a different configuration with a blunt tip and fins here which get fitted into the medullary cavity tightly. And this is the sign plate that we have. It's the screw are called 3-step screw because of the 3 diameters, 6.5, 4.4 and 4.5 and 3.5. They give stability in compression, axial and interfragmental compression, and allow self-dynamization, and locking can be done without CM, and that is the invention of Dr. Zirkle. This nail is much stronger than the nails that are available. And comparative analysis is that the stiffness of this nail is 47% higher than the other nails, and this nail is 159% more irreversible deformation. Now, what is the philosophy of sign nail? Dr. Zirkle is a graduate of Duke University, and in 68 to 69, he had to go. He was deputed to Vietnam during the Vietnam War, and then he saw a lot of hardships there, suffering and misery of young men. And then he came home, did his fellowship practice for about 14 years, and then what he saw in Vietnam would always come as a voice in his heart, calling him for his mission of taking the SIGN project to the low resource income population. The SIGN nail is like a peacemaker. Peace is to be made wherever there are conflicts, and peace wherever there is natural disasters. So SIGN is always present wherever there are natural disasters, and to name a few which are mentioned here. And now SIGN has been working in about over 55 countries with 354 hospitals, and I'm just told by Dr. Zirkle that about 3.5 lakh nails have been implanted. It's a non-profit organization with the largest database. He makes 4 trips a year and has 37 publications, and goes to all places where and he teaches them and educates them, and also revives their spirit, those who are working for the SIGN nail. And also the various managers or SIGN nail surgeons get to come to Richland for annual conference where the newer innovations of the SIGN system is being taught. And for all this work, he has been awarded the Humanitarian Award by the Health Ministry of USA. Thank you, friend. I present to you Dr. Louis Zirkle.
Yes, sir. Thank you. Thank you very much. So, according to the request, I am just playing that video Dr. Zirkle sir has sent to us. Right, sir? Zirkle sir?
Yes.
Are you going to speak over that or no, sir?
No, there's sound with it.
Okay, there is a sound. There is a sound. There is a sound. Let me check it. Just a minute. Okay. Sorry, sound is not coming. So let me do it again. Because I have not included sound also. Are you getting sound or you're not getting sound? You're not getting sound.
Yesterday we got sound.
Okay. No issue. I will open up in the...
He said no, there is no sound in the movie.
No, there is a sound, sir.
There was sound. We heard.
Yes, it is there. It is there. I will make it. I will make it possible. Just a minute.
Play the 30-minute, please.
Yeah. It's 30 minutes, but I will stop at 20 minutes so that we can discuss also.
Okay.
Let me open up in the quick movie file because the file is a little bit different.
No, I think that this one starts that way.
The voice will come now.
The vision of SIGN is creating a quality of fracture care throughout the world. We've tried to follow our vision in every decision that we make, and this is a very important statement to us. This video that we're going to show gives a little bit of a synopsis of SIGN, what we do, shows the patients, which are the real crux of our goal, and I hope you enjoy it. The past 20 years of working with SIGN have been like climbing a mountain. I remember that Nelson Mandela talked about climbing a mountain. He said that I've worked hard for the past years to climb the mountain, and I'm tired. And when I get to the top of the mountain, I will get a chance to rest. But when I reached the top, there was another mountain to climb. And that's the story of SIGN. We've been working for 20 years with many agonies and many ecstasies to help people around the world, to help the poor who have fractures. Incidentally, for you medical students, this whole relief effort was run by Pakistan medical students who contacted people around the world to come and assist them. The man in the bed is a very important symbol for us. He was one of the agonies. I had taught in this country for many years, for about a month out of every year, giving lectures. And I went to Vietnam and then came back to Indonesia, where this man was. One of my students was there, And we were making rounds, and we saw this man, as well as many other men on the ward like him. He'd had a fractured femur, and he had been in the fraction for 3 years. He was depressed. His family stopped coming to visit him because they couldn't afford the small daily hospital charges. And I said, why? Why is he still here? We talked about this. We lectured about this. And you know how to fix these fractures. And the surgeon said, he cannot afford an implant. He said, and by the way, the implants that you send over here are made for United States, and we can't use them because we have power surges. And these power surges prevent us from using any power equipment such as instant imaging or even reaming. So I returned home to Richland, Washington, where we started working on a way to circumvent the use of electricity. Gradually, we evolved a model of education plus donation. They had to be donated because the poor cannot afford implants, and the implants had to be appropriate. Now, we have worked on all three of these factors: education, donation, and appropriateness of the implant, and I'll tell you a little bit about this. The C-arm is considered indispensable for treating fractures in the United States and other developed countries. It's where you can make instant images to know the position of the screws and to put that screw through the bone, through the slot of the nail, and out the other side without looking at it. We developed a way to do this with slot finders, and I want to say that many people have helped sign, and many people continue to help sign. So it's almost a global effort to help the poor in developing countries. We had to realize that the canals were different around the world. They have the same basic shape. By the way, we have more sameness and more similarities throughout the world than we have differences, but we have to account for the differences. Differences in bone density, differences in the curvature. So we had to make a condition that could suit and fit many canals around the world. It had to be economical. And I want to give credit to many people that I won't name because there's so many of them who helped us in this effort. We started off as a tibia nail. The tibia, if it has an open fracture, that means the skin and muscle above the fracture is opened, has the worst results because there's more infection there. There's not as good a blood supply, and the bone is nearer to the skin. So we started off with the tibia, and it worked really well. This fracture here was one of the first ones in Vietnam, and it was done without a C-arm. Remember, we had to put the nail down through the canal of these fractures to accomplish this. This girl showed up with a fractured femur and tibia. So we thought, what can we do? We went home as usual and thought about it that night. And came back in, put the nail down the tibia, and then we ran another nail up through the knee, up through the femur. This was new at the time. There was one article in the literature that I learned many years later in retrospect, but this was a new concept and it worked well. We were communicating back then by mail and by picture. And this picture came in of the girl standing on her fractured leg 6 weeks after surgery, which was very encouraging to us. I then received another email with pictures from Han Quoy Quang, who was a good friend in Vietnam. He said, we put the sign nail through the proximal femur to take care of those fractures there, and it worked really well. You can see by the x-rays before the surgery and after the surgery. And I said, oh no, we're going to have to invent and innovate a new nail. But he said, no. He said, just put the nail in and let it rotate where it will. And this has worked very well. We've not had to revise or change the shape or anything about the sign nail for the past 20 years. And I give the credit to the Vietnamese surgeon for helping us here. This man is from India, where they eat with their hands many times, and he had had 6 operations. He finally had the sign nail and his fracture healed. If you look at the bottom of the nail, it looks like it should be blocking motion, but you can see the motion that he has. And this was started by an Indian sign surgeon. We then started working on the hip, and we had to develop a modular system, a system that could be used for many different sizes of hips and many different types of hip fractures. So it's modular, different sizes of the implants, and you can use different combinations. And this turns out to work very well for us. This is one of the first cases in Afghanistan. This man is helped up by his family to mobilize. In the developing countries, most of the physical therapy is done by families, and he did very well. This young boy in Mongolia was the first pediatric nail in Mongolia. Here he is standing on his leg after surgery one day. He did very well. Also, and the Mongolians have led the idea that you can put a nail through the bottom of the femur, up through the growth center, without causing damage if it's done in a specific way. This young boy was climbing a mango tree in Kenya and broke his femur after he fell out. He's out in the field looking at that mango tree again, just showing that he feels no disability after his surgery. When we first started teaching sign, we traveled to different countries, we gave lectures, and then we operated together to learn the sign technique. So we combined a lot of different kinds of learning, and this was very helpful for us. But unfortunately, nowadays, we have so many surgeries, we have so many programs that we can't go around every program. So we've had to lean more toward digital teaching, and this is working out very well. The SIGN conference is held every year in Richland, Washington, but we have conferences around the world in order to teach. We still use the older methods of lecturing, but we have many breakout sessions now at our conference, including a bioskills lab for the difficult fractures. Procedural memory is very important. This means using your hands to accomplish what you've learned. And this is a very important aspect. It works well, and we try to use as much hands-on training as possible. We make our own implants here in Richland. We have a wonderful staff here who work hard to manufacture, innovate, and evaluate our implants. Creativity is, in fact, intelligence, having fun, according to Albert Einstein. And we agree with that, and we practice creativity here at SIGN as we learn more about fracturing. We even are starting to do machine learning to evaluate the fracture site. So as we start our second 20 years, the connector between the two mountains is our database. The database is so important for us, and because it helps evaluate the past and looks at where we can help in the future. It connects surgeons around the world in 51 countries. Site trips are made to teach our complex fractures as well as the SIGN technique, and the SIGN conferences are always well attended. The database evaluates the SIGN surgery, as I mentioned. There's 144 surgical reports because we didn't start it right when SIGN started, because we didn't have the technology. Now we use the database to evaluate new ways to treat fractures and to evaluate whether we should intervene with more surgery if the fracture looks like it's not healing fast enough. We're dealing now with complex problems. We want to help deformity. We want to help patients with pelvic and acetabular fractures, and we're looking at patients that have spinal trauma to help them. These three complex problems require hands-on work. They require working under the supervision of a mentor for sometimes months, and we've started our pelvic and acetabular fracture fellowship in Ethiopia. Deformity is important. Deformity, these kids with deformity stay home. They don't have a hope of living a normal life, so we want to help them. This was done at the Tebow Hospital in the Philippines. Mentors are rising. This is Sami Hailu from Ethiopia. We're at a conference in Kenya, and he's teaching how to do pelvic surgery. And this is very important. The two aspects. One is the pelvic fracture surgery, but also the mentors are coming from developing countries. These surgeons are really good. In fact, they're as good as any surgeons in the world. They have it hard because they don't get preformed plates, pre-contoured plates that you can buy here. They have to bend their own plates. They don't have C-arm to use, so they have to be more skillful with their hands, and they are. Spine trauma is important. Right now, the patients that have spine trauma in many places are not treated appropriately, so we're using our model of education plus donation of appropriate implants. And this is the hardest part, to get the appropriate implants and to use our database to evaluate what we've done in the past and what we can do in the future. SIGN has attended disasters in Indonesia on 2 occasions, and then in Banda Aceh for the tsunami. In Pakistan, we were asked to go to treat the people, and Haiti was another disaster where SIGN played an infinite role. In Nepal, 95% in Nepal, 95% of the patients with fractures were treated by SIGN surgeons. We decided that the best way to prepare for disasters was to establish programs in the countries which are likely to have earthquakes and supply them with the equipment. And we're very pleased that SIGN surgeons have taken charge of disasters in the Philippines and in Nepal. This Venn diagram gives an idea of the complexity of SIGN. Education is very important, but education intersects with the database, because we use the database both to evaluate what we've done and what we can do in the future. Education and the database interact with implants, because we can innovate appropriate implants. And the elephant in the room is funding, because we are having a bigger and bigger budget every year. But I want you to notice that in the middle, that intersects with all of these aspects is the patient. The patient is first priority for us. This is a very famous saying about give a man to fish, feed him for a day, and teach a man to fish, and feed him for a lifetime. This was recently stated in an article by Haitian surgeons about SIGN in Haiti. And we strongly believe in empowering our surgeons. There's a challenge, however. The challenge is that poverty.
Sir, we are keeping 10 minutes video later on as decided by Dolby. Dolby, is it okay?
Whatever you say.
Okay, sir. So we are starting now the case discussion. I think after this introduction slide, there was a cases, I think.
Yes.
Yeah. Dr. Yu is going to share his case, I think. I've started from here.
Navin, Dr. Tanna to present the...
Okay. Tanna sir, will you share your screen, sir?
Welcome, Dr. Tanna sir.
Tanna sir? Tanna sir, are you there? Sir? I could not get the response from you.
Unmute. So to add to the story, Navin bhai.
Yeah.
In 2010, I was in Myanmar on an AO SEC course, and somebody stood up and asked a question, which is a very interesting question, still haunts. He said, can you do a hip fracture pinning without an X-ray? No, forget Siam.
Tanna sir, can you share the screen? Because next is your presentation, sir. Yeah. Go ahead, sir. Go ahead.
Tanna sir is probably going to take us to that era where, doing an interlocking nail without Siam was really a challenge. And I think his work is legendary and innovative. And I think the journey from the beginning is what I think will be interesting to hear.
See, I think this is, am I heard, no?
Yes, sir. Very well, sir.
Very well.
Dhaval asked me the evolution of this nail and how we started in India interlocking nailing. Why interlocking? My early pilgrimage to the American Academy, I found at that time the AO had introduced the plating, and that is all what we are continuing. And then I realized that there was interlocking was the buzzword there, and the plating had gone into the background. You remember the rigid fixation. It started initially by Muller and everybody.
Rudy
yeah. So then now the interlocking was a buzzword, and in India we could never do the interlocking because the Siam didn't exist at that time. That hooked me. That how come we cannot do the interlocking? Siam was not available in India, but there was no nail also available. I am talking in 89. It hooked me. My first nail was this K-nail femur. That time we were doing K-nail femur. I made a few holes on the upper and lower end, as you can see here, so that at least one I'll be able to put screws when I open blindly on the tibia. I bent a little on the interlocking nail, and the nail was ready. This was the first nail in a comminuted tibia into the public hospital. I fixed up the fibula. I put the interlocking nail. I made a hole here. Somewhere out of these 3 holes, arbitrarily wherever I felt, I made a hole. I made a drill hole, and I saw the hole there inside in the tibia, and I put the screw. And lower down, I made a big big cavity in the bone, small. I found these 2 holes. I put in a plate, and I did this interlocking distally and proximally. And lo and behold, I think this worked.
So plate used as a washer.
Yeah, because at that time I started with only the drill holes, but I couldn't find the holes. And because this is the first, I am talking about the first interlocking ever done in India. This is how it was done. And then my boys who were there in the medical college, you can see this is 89. My boys who were there, somehow or the other, this patient did well. So we went ahead. This is how it was. This is the only X-ray I can really retrieve. Distally had to make a big hole in the bone to find the distal tibia locking holes. So used a small recon plate and the interlocking was done. Patient was comfortable. We started him mobilizing and did everything, and he was not in the plaster. He was mobilized, and then we were surprised how it worked. So interlocking saga started from here. This was the first thing which happened. So these are all the canal femurs in which we made the holes. We made a dynamic hole, we made a static hole, and all this you can see here. Then the nail evolved, and slowly these are the second generation nail. This is the first generation canal femur in which we did it. Thin canal femur and shorter one, we did it for the tibia. So canal femur used as a tibia nail. So the same canal femur, short one, was used as a tibia nail. And I made this interlocking, one thing interlock. This, you can see this. And this is how it was so nicely it started. And then we continued these things. And these nails were, when we were early in making, with thin nails, they were bending. So this is how it is. We made these few screws, shaft screws, ordinary full threaded screws, normal screws, and these are all the canal femur in which the same camel instruments we were using. We made the dynamic hole, 3 holes like that. As you can see, this is how it started, and thin nails started bending. So the thickness of the nail increased from 1.2 we started with, whatever the available metal to us. Then it went to 1.5, and ultimately, in order to be really having a decent nail, I had to go up to 2.5. This is how I made the nails since they were bending, and the next phase was the tibia nail. This was, I was using a canal femur, so we started making a tibia nail. The tubes were available in a steel market, 8 to 9 millimeter on average nail which was needed. So the new nail evolved, tubular tibia nail. This is how the tibia nail was evolved, and this is how the introduction we started. This is all, there was no designs, nothing, we just started it. This was the introduction, as you can see. It was locked into here, the same thing with the femur slot. It was done, and then here it was bent arbitrarily. There was no jig or anything. This was bent arbitrarily, and I started doing the nailing, and this went. Then this was the insertion device. This is how beautifully it worked. This screw will go from there and it will lock inside, and then here is where you will hammer it, and here is the one which you want to really take it out from this hole. You could take it out. So this was how it was devised, the insertion device. And then we had to make the extraction device if you had a problem. So this was that early extraction device in which we put in, and with this canal femur extractor, we could extract it out. This is how I am talking about in 90. We started it, and this is how interlocking was easier with the anterior posterior hole. So I converted those nails. Originally they were side holes. I converted them to anterior posterior holes, because then you can see these holes very well. You don't have to turn the side of the patient. Proximal and distal locking was done only with a C-arm tricks, which was done, but now here we didn't have a C-arm. So I started with the X-ray machines, and this is how they were done. I'll describe in a short how we started in the X-ray machine. This is how it was. I took another tibia nail and arbitrarily found out where the holes were identical length of a tibia nail, and arbitrarily I would put in a K-wire in the center, and then I would see this X-ray and find out how much is the K-wire medially, laterally, above, below. So this is how it was interlocking without C-arm, only with the X-ray and identical nail. This is how it was started. Why did general use nail came into picture?
Sir,
Till now,
can I add here, sir? We had a 9 square metal piece with the holes, and we were putting that on that area of the tibia, and then we were taking X-ray. Which hole is matching with the tibia nail? We were drilling.
I know.
That was the device we made. Yeah.
This is
9
all
square.
You made it after my struggles.
Yeah. 89, sir. 89, sir.
Yeah.
When I passed.
Till now
at
only
that time.
I was doing it in Bombay. And
Okay,
my
sir.
residents were doing it in Nayar Hospital.
Jawar bhai is knowing that we were doing in LG Hospital. And
Yeah.
first Siam machine came in LG Hospital.
Okay, I give a credit. I can give a credit to you. You started interlocking it.
No, sir. Not a credit. That is the one
Okay.
value addition that to
Yeah,
locate
I
the hole,
appreciate.
we
Yeah.
used the 9 holes from the hardware market, that jali, steel jali.
Yeah,
And we were putting as a template.
Yeah, I'm fully aware of it. What was done later on.
Yeah.
This is how initially we started, and this is what I am describing. Till now, only I was doing in Bombay, and my residents who went from Nayar Hospital in the other hospital, they started doing. So other surgeons in Bombay got interested. Residents went to other hospitals, started doing it, and they could do it without Siam very well. They needed nails and bought the single supplier was doing the nailing. I read many papers on this and people didn't believe. In one paper, I was talking in Vairok, Dr. Taraparawala from Bombay Hospital commented, how can you only do this without Siam and nobody else can do it? While I read that, somebody from Sholapur, Dr. Daga, was doing this something like a similar things. These two comments made, they were enough. I started the second phase. Standard nail, now it became a standard interlocking nail and it was named as a Tanna nail. Became more and more, and many companies copied and sold that as a Tanna nail, and ultimately the nail was marketed all over India. And that was the first phase of a tibia and femur nail. So now a general use standard nail evolved. I had to teach them. So I did 75 all India workshops, evolved in all of them. Many companies copied initially. There used to be cell and they say, sir, Tanna nail is available even in Faridabad, and it is available there. So they all copied. I never made a copyright and I wasn't bothered about it. As a matter of fact, when they copied and it was evolved as a Tanna nail, my purpose was served. Most started interlocking. That is all what I wanted because the money part of it was not important to me. God was already given me a lot of money otherwise. So these are the early slides which I talked about it. Interlocking tibia, Indian way, no IITV, femur canal 9 mm above with holes at the end, procedures. All these were my early workshop slides. And this was the fully introduced, the control, the rotation and everything. And this is how I started the interlocking nail. And it was published in 94. Interlocking without Siam, it was published in JBJS. And I was asked to write a book by JP. So in 2000, I wrote a first book, Interlocking Nailing. And that, it seems, fortunately, it became the textbook of interlocking in India. And I think majority of you people read that. And that is how I had described all minor details of interlocking, how to execute it. And this is how it was done. There is a last edition now has come in 2019. That is the 4th edition which is there. It is coming there. This is how it was done. I'll give you a small gist of it. These two identical nails were taken. These K-wires were seen there. K-wires were judged where they are compared to the hole. This is, as you can see, how much medially I have to go, how much laterally I have to go, and on that basis I'll do it. So these were the ones. At times we were on the edge of the hole, so this was made a bigger hole. And this is how we started off, made a line, made those things. And then this is how we started. Then often enough, the holes became bigger like this, but it didn't matter. The interlocking was continued. It could be done there. And this was the Tanna's interlocking. It is in 4th edition. This is how it has been there. And I faced this newly educated surgeon started doing this tibia nail, and he had this entry. This is one of the senior surgeons, had an entry from tibial tuberosity. So actually the whole, you can see the tuberosity came out. So I started the next phase of workshop. Doing interlocking was not enough. Doing it well was the theme. So next phase I stopped. new nail design for a while and concentrated on doing it well. By this time, the CM got introduced all over. Some of you may not know that I had the first Indian CM in my clinic about 12, 15 years back after the interlocking wave. I traveled, it was crazy. Craziest was I went to Gorakhpur. You know where it is? It is near a Nepal border.
Yes, sir.
Bombay 6 a.m. to Delhi 8 a.m. 10 a.m. Delhi to Lucknow for a Varanasi. Varanasi to Kar, Gorakhpur. I reached there at 5 p.m. 6 p.m. to 11 p.m. at night workshop and dinner. A.m. 6 morning workshop till 11 a.m. And the journey back, and 40 attended, all 40 surgeons in Gorakhpur attended at 6 a.m. Same journey back and 9 p.m. to Bombay. Because being a Gujubai, I didn't want to spend any extra days except a weekend. And this is how the Gorakhpur was there. This is how we started. Didn't go to Manipur. Had to have 3 days, and so I didn't go. Well, it was fun till the wife threatened talaq. Every weekend I was out, and I had to give an appointment after 2 months or 3 months to be in their city. Compression nail was the next. This became my current used nail. It is an Herzog band high, lower interlocking hole, lowermost, and it has the capacity to compress the fracture. This was the compression nail I had designed years back. This is how the same thing now the AO has been doing it. Now all these are the compression nails I started. This is the compression nail. You can see there was a primary healing occurred, but while doing the compression, the nail will bend. I'll not do anything with that. And ultimately the static hole will be there initially, the compression nail, typical what we're talking. Then it went on adding all the nails. Supracondylar nail, knee arthrodesis, humerus nail, tibio-talar calcanean nail. I'm not sold by forearm nails, and so I didn't do it yet at that time. And Polaris nail, I feel this is what is a nail which is today, which has come by synthesis for 4 holes in the center. This is the one I had devised at that time. I feel this nail is the most suitable treatment for fracture which are proximal humerus, non-articular. This is a typical Polaris nail. In those days I did that. And tibiofemoral arthrodesis nail, this was needed. It was not a straight nail, it is a slightly curved nail, and that is the arthrodesis nail came. I feel the history as I'm taking it, it must be real and complete. I do not want to push unpleasant happening under the carpet. And I also want to thank all those who participated in this saga. Shusruti Instrument Company, they were the first who copied original interlocking instruments for me. I could lay hands on, that was the AO instrument which I borrowed from Dr. Sudhir Babhulkar, and that was the first copy which was done of AO instrument. After making those instruments, I asked Sushrut Surgical to make the nails which were designed by me. Ajay Pitre, the boss of Sushrut, he told me very politely, "Sir, you wanted I made those instruments for you, beautiful instruments you made, exact copy. Out of respect for you, but I feel interlocking is not a good business. So, sir, please excuse me, I do not want to do the nailing." Later he confessed it was a wrong judgment. He could never become a major player in that part of a trauma. Even today, interlocking is not his territory. It has been taken over by other people. Dr. Sangeet Gawale was a part of each and every workshop as we started, when he was working with me as a fellow, and afterwards he became a full-fledged surgeon. We had many pleasant memories all throughout. Apart from, after that, Dr. Shiva, and slowly many more have contributed, like G S Kulkarni, Sunil Kulkarni, Sudhir Babhulkar, Sushrut Babhulkar, and many more to follow. Garigune, a massive user of PFN and incisive study of it, how in a remote place like Chandrapur, he can do such terrific work and produce results and incisive observations. This also proves my theory. Each one of us is capable of doing the best orthopedic if we have that passion in the smallest setup also. In conclusion, Indian nailing has traveled a long distance. Saga continued. Now I talk on, I am not an interlocker. I am an orthopedic surgeon. I also do plating. Interlocking is here to stay, whether you are a nailer like Shiva or an orthopedic surgeon like me. Thank you very much.
Thank you, sir.
Thank you, sir, for for a great information, innovative and visionary show that you gave us, telling about the history of the nail. We wouldn't have ever known about it. And because of your incisive observation, the interlock nail gave birth in India much before the Western world in terms of without imaging was available. Thank you.
I think it is now turn of Dr. Yu, I think.
Yeah, thank you so much, Dr. Antao and Dr. Dava and organizer for inviting me to have a talk here. And also thank you so much, Dr. Zirkle, for a very honored for me to meet him today. So for the sign nailing in Vietnam, next.
Yes, sir.
Navin by next.
Yeah, next. I would like to talk a little bit about the trip history. In 1999, Dr. Zirkle by himself went to Vietnam and running two side projects in Vietnam, in Bình Dương Province and Chợ Rẫy Hospital for some first tibial sign nail cases. And after that, it was very successful for bone healing to treat for the tibial fracture. And after that, he attained the indication to the femoral fracture. And the first cases do the rate for femoral fracture that in Chợ Rẫy Hospital. And after that, for the anti-ray nailing in the Bình Dương Hospital with Dr. Hang Khởi Quang. And for many successful series of successful with the treatment for many tibial and femoral fractures. After a few years, the program, the SIGN-GOA program, extend the training and implant donation to other provinces around Ho Chi Minh City and in the southeast of Vietnam. And also the orthopedic surgeon in Vietnam gives some feedback for the modified features of the nail to best fit Vietnamese patient and orthopedic surgeon requirement. And it will widely application in nearly the whole of Vietnam. Next.
Yes, sir.
And next. And here I will present some currently treatment of the tibia fracture with the side nail. Currently at my hospital in Ho Chi Minh City, the first case that is the female patient, 34 years old, he has traffic accident and got the closed segmental fragment of the left tibia and fibula, neurovascular intact and no compartment syndrome. Normally in my country for the closed fracture, we use the immobilization for temporary immobilization with the long leg cast for 1 week and then have the selective operation. Next. And after 1 week with immobilization, the patient go with surgery, of course, with closed reduction and without C-arm for the tibia fracture. Most of the tibia fracture, we don't use C-arm, and we just use the aiming from the side nail system. And we do with the finger 4 position. Next.
Hugh, can I interrupt? So can you go back to that slide back?
Yeah.
So what do you do is that you only ream the proximal fragment?
No, for the tibia, most of the case, especially in the woman, we don't rimming the canal, and we use the 8 millimeter diameter, and we use directly the nail at the nail tip to find the distal fragment. And we can use the sensation to feel and to reduction and to insert the nail directly without rimming.
So you would never land up putting a 9 or a 10. You say that you most of the time will put an 8.
For the TBR, most of the case we use with the 8 millimeter, sometimes with 9 also, but not go with 10.
Okay.
Because the small bone in Vietnam, Vietnamese patient.
Okay. Go ahead. Yeah, thanks.
Yeah.
This is the both operations X-ray. The bone is reduction is good, and 2 months after the healing is on process, and after 4 months the healing is progressed quite well, and the patient is full weight bearing and return to nearly normal activities.
Sorry, doctor, to interrupt you.
Yeah.
Now, as I understand from there, what we are aware, the distal locking is also done, which is purely jig attached proximally. Is that right?
Yes. We normally for this we do with the proximal and then do with the distal. Yeah, by the top.
So distal also, even the distal interlocking is done with the zig which is attached onto the handle, is it?
Yes, sir.
Okay.
Sorry, could
the
you?
Question is, the distal locking is also done through the jig only, or it is a freehand?
No, it's not freehand. After we do with the proximal interlocking, we fix the aiming, and then we use the jig, and we do not the freehand.
Okay, so it is through the jig only.
Yeah, it is the jig based into the handle.
Can I add here? Sorry.
Yeah, please. I will not be able to see all the videos of all the faculties, so I will not be able to see their gestures because the full screen I have done. So you can take your decision to give input. Yeah.
I'd like to add here, Hugh, that when doing the distal, doing proximal, it is almost entirely jig based. But doing the distal, you have to do the proximal hole first. That is the proximal cortex you have to drill. Then you use your slot finder to find the slot. And after you get your slot finder done to the opposite cortex, then you drill through the cannulated slot finder and find the drill is complete. So it is not entirely jig based.
Right.
So it is jig based only. You finding the hole from the jig only, no?
No. We find it with the slot finder.
You are absolutely right, but partly you are using the jig to find out approximate where the hole will be. Yeah,
of course.
And the what exactly you mean by shot finder?
Slot finder is finding the nail slot is the slot finder. Oh, Hugh, please answer.
Sir, it is like this. There is have the distal.
See, because why I am asking is, main thing which is new in the sign nail, as I understand is, it is the same nail which is used for tibia, femur and humerus. Am I right? Except the length.
Yes, sir.
And interlocking is purely jig based.
Yes, sir.
Yes, sir.
And so this after you have put in the jig, you confirm that you are in the hole, is it?
No.
Once
we can just guess.
Because I think why I am asking is, it is the main speciality of the sign nail. So please describe that interlocking part.
So it is the specialty in the fact that we can be sure almost entirely that we are in the distal slot with the slot finder, not with the jig.
Dr. Farooq, can I interrupt?
Yes, sure.
Yeah.
You have a distal jig, sir, and you have a cannula which fits into it, and you have two drill bits of differential diameters. So first drill bit is a bigger diameter, and to that, once you drill the outer proximal cortex, then it's easier for you to put into that cannula the slot finder, which if you have drilled the hole right at the hole on the nail, the slot finder will go into the slot in the nail. or the
Okay.
oblong and get locked.
So near cortex is over drilled to see the hole, to match
not to see the hole.
Not see the hole, not see the hole, to feel the hole, to feel the hole.
To feel, not see.
And not see, to the feel, to feel it.
And you know, not every time you are not sure that it will go through. So you have to adjust. Then you.
So
this is more important because
remove
until
the
now
and do free hand.
The distal locking can be done with fig only. There is no need that.
So once you
bọn trong prap tha cái miếng sai này thì lại còn đủ speaker.
Hello.
You change the drill bit.
Mới khởi phát phòng khởi thì tặng cái đạn lại.
Hey, Antao, we can't hear you properly.
Khai clear giờ này cái trong mới có miếng speaker là all.
Who is speaking? Who is speaking? In the background, somebody is speaking. Please, one by one only, please. Somebody is talking personal talk, I think.
Is Mr.
Tufort, please mute your
please. Tufort, mute yourself. You are doing telephonic talk, sir. Oh, it's very difficult for me because I have set the screen. So if I'll change the screen, the screen will change. That is the only issue with me.
Actually, the nicely thing for the size system that is the slot finder, because the horn, the open horn, the slot on the nail will fit and lock with the slot finder. And in case you make the small incision in the distal interlocking position, then you drill the near cortex. And after that, with the zig, with the hammer, you insert the slot finder into the distal interlocking slot. And if it's fit correctly, you cannot rotation the slot finder, and you can feel that exactly the locking slot. And then you can drill the far cortex, and then you can insert the screw.
Right. So as I understand, the proximal hole which you are doing, the near cortex hole, is with a slightly bigger drill hole.
Yeah.
In which it is like an insert sleeve. You are putting a sleeve or a slot finder, which you are calling.
Yeah.
And just a minute, allow me to talk. 2 minutes. Navin, 2 minutes.
Yeah. Yes.
So that slot finder, you will push it inside in this bigger hole and slowly maneuver it so that it can goes into the hole of the nail. Am I right?
Yes, sir.
Yes, sir. Yes,
and
sir.
once you go inside the hole of the nail,
it will lock.
So you will be able to know that it now fit in, so it will not move. So that slot finder is a thinner one which will fit inside the hole. Is that right?
Yes. Yeah, that's right, sir. That's right, sir.
Yeah. Okay.
Then,
that's right, sir.
Sir, Tanna sir,
yes.
Just a minute. There is one input from Dr. Dayanidhi sir that do not fix the proximal holes first and use a guide wire to use the we were doing without Siam tic-tac technique.
But it is a solid nail.
Navin, 8 minutes. I think that is a different thing. That is a solid. This is a solid nail. So
this is a solid nail.
It is all of us started doing it. Shiva introduced it. We all aware of it. This is a different. This is a different type at all completely. So in this slightly hole which is bigger, so you can sleeve. You can really change it slightly up and down till the time it will fit inside the hole. Am I right, Antao?
Yes, sir.
Yeah.
That is the reason why screw is having a bigger head.
Yes.
That's right.
To compensate that.
That's a step screw.
Yeah.
Navin.
Yes. Yes, sir.
If the slot finder not fit the slot of the nail, then it will move completely. If it is the slot finder, if it is inside the slot finder and is found its path, then you cannot turn the slot finder.
Yes, only 10 degrees.
The slot finder is cannulated so that you can
You can drill through.
Yes, now it is clear.
Yes, sir.
Now it is clear.
So why not use Eminent in the wire?
One last question.
This was invented to nail in the austere situation, but there is no image intensifier.
But now with imaging is back.
Now you have.
No, if it is done into the poor country where there is no imaging, this
No,
is
we
our
are talking
same
of
thing.
That is all
Same
right.
thing what I started, they are doing it without image intensifier, and this is a different way they are doing it. So that even in the countries where it is not available, it can be done.
Yes, sir.
Yes, sir. Yes, sir.
Quite efficiently done anywhere.
Yes. I mean,
So Hugh, one last question.
Yes.
And everybody that applies to all the sign nailer, because you got great experience. So with so many times the surgery done, how often or how in percentage, how often is you are accurate with the distal lock? 95%, 90%?
I think it is 90%.
Okay.
Yeah.
See, other thing is, if you just try to hammer the nail, then there's the chance of the
deformation
rotating and you not finding the slot, because as you hammer on the nail, the junction of the
get loose
handle into the screw becomes loose.
Yes.
At the top.
Now,
another point is when you under rim, then you have to strike the nail to place it in the canal, and at that time there is a minimum deformation will then distally will not find the slot.
Can I ask the question? Can I ask the question, sir? How
Sure,
many
sure.
times do you feel that when it is an unrimmed nail, solid nail, and you developed small splinters when there was undetected fracture lines were there, fragments, butterflies which was not separated out, and that got separated out? Because you are not going on the guide pin. Yes, it is a solid nail.
Yes.
So you may not be completely in the trajectory of the proximal canal and the distal canal many times. You just negotiate it, but many times does it happen of splintering of the distal fragment, which was probably there, undisplaced splinters were there.
Yes.
So when I see a splinter in the bone or potential hairline fracture, which is likely to I try to use a thinner nail, or I will study the medullary cavity with my ruler's template and on approximately put say 8 or 9 millimeter. I will not go to 10. But if the medullary cavity is very narrow, then I will slowly ream the medullary cavity with the reamer. Also,
the reamer you will do with the guide wire, is it?
No guide wire.
You have got
only for the reaming.
Hand reamers. You have got hand reamers.
On filling, hand trimming with the filling. Don't use the guide wire.
Just like the hand reamers.
Same with the femur. Same with the femur.
Yes.
Yeah, same with the femur.
So you will only ream proximally, and distally also you will ream with the hand reamer.
Yes. Those are those are first ones are cutting reamers, and beyond 10 those are blunt reamers. So when we negotiate the distal canal, there is less chance of vascular damage or damage to soft tissue.
Okay. And these reamers are solid reamers, are one-piece reamer, or it's a welded one? Because sharp part is welded many times in the reamer, solid reamers.
These are one-piece reamers.
One-piece reamer and solid reamer.
And a bit flexible.
They are not very rigid.
They are flexible.
Yeah.
A bit.
They are flexible. Okay.
A bit.
No, we have not seen that pictures. That's why we are asking, sir.
Are you going to show exactly the procedure? Anybody is going to show the procedure?
Navin, there is no guide wire in the trajectory. There is no guide wire.
There is no guide.
Solid nail.
No guide wire. It's a solid nail.
This is a solid nail. But the question is, why not to ream with the guide pin if you are using a flexible?
Now at least when it is available. Probably originally when it started, it wasn't there or something, whatever, understandable. Anyway, chalo, the way they are doing, we are trying to learn that. Okay, please carry on, doctor.
Yeah. So the second case, also this is more simple, the simple fracture of the tibia, also closed fracture of tibia, but open fracture of the fibula. And we did it emergency with the debridement of the fibula open fracture, and then we fixed the fibula with a key Y, with the 2 mm key Y. And for the tibia, we do the close reduction and side nail fix the side nail with the close reduction, and also the same methods. You can see the nail here that we use at 8 mm nail diameter. So that reason why you see it's a little bit smaller to the canal, canal. So we untrim. Yeah.
Okay.
For some situation with the simple fracture, and if we would like to use the bigger nail in the in the large people, we can trim with the but we need to close reduction, and we try to keep the reduction, and we can feel the reduction first, and then you can trim. And when you rimming, you can feel it can go the distal fragment or not, and when it end, you can feel exactly. Yeah, and then you can go with a bigger nail in the simple fracture. Yeah, next.
Yeah, same.
Yeah, the same. And this is the 6 month, the bone healing well for both tibia and fibula, and the patient weight bearing, full weight bearing, and normal activities. Next case.
Okay. Even the thinner nail interlocking worked here.
Yeah. Because you do the interlocking, so you can control the bending and the rotation. So even with the small size of the nail in the big canal, it's still working. And especially in this case, that is a simple fracture.
Okay.
Yeah.
According to the studies of Paul Turnetter and all, which is established in his Journal of Orthotrauma in 2016, rimming does not affect functional outcomes after open and closed tibial shaft fractures.
Yes.
Yeah.
Okay. Okay. Dr. Zirkle wants to say something at this juncture. Sir. Zirkle, sir.
He's been muted. He needs to be unmuted.
But I am not muted. I am not muted, and I am sharing the screen, so I will not be able to see whether
you can unmute him.
I think Dr. Hugh.
Yeah, we got it.
Yeah.
Is right, and as everybody, we use the jig, the target arm, basically to find the hole. We make the hole larger with a hand instrument, and then we put the slot finders in through the cannula to find the slot. And we have 3 slot finders. We have a solid slot finder, and I don't know if you can see it. This is very valuable, the curved slot finder. And finally, we have a slot finder with a hole for the drill in it, and it works well. The reamers are hand reamers. We get bone grafting as a result of the hand reamers, and we can put this in the fracture if we have to do an open reduction.
Okay.
Okay.
So you collect the ream product also.
Yes.
Yes.
Yeah.
In the fluids of that reamer.
Yeah, in the fluid of the reamer. Yeah, because you do the hand reamer, so it's not much energy and it not burn the bone debris. Yeah.
Right.
So this is the next case. Got from the other hospital. The patient moved to our hospital. The 63 years old male with the motor vehicle accident 10 weeks ago, and have the open reduction and internal fixation with the locking plate and locking screw. And after 10 weeks, he fell down at home, and it bent the leg, and deformity of the leg and deformity of the bone in the X-ray. So in my hospital, our colleagues decided to do the new operation revision to remove the plate and screw, and it changed the implant with the side nail. And when he opened the fracture line have the oblique, so he do the last screw. one lag screw for from anterior to posterior, lateral, medial lag screw, and with the side nail. At this test, he don't apply any bone trap. After 6 weeks, the bone look here in the AP view a little bit displacement, and it it's nearly loosened the lag screw and the bone's displacement. And you can see here the locking screw in the proximal one, the most proximal one, also loosened after 3 months. But when you close look here in the hospital, they use the interlocking screw, but they cut the screw because they don't have the available enough size of the locking screw, so they have to cut the screw. That's the reason why it makes the whole construct not very stability, because the locking screw will be cut, so the range is not cracked, the distal cortex not quite good, especially in the sub one here, so it's loosened. And of course, the patient needs to do the revision surgery, repair the implant, and do the bone trap, and apply the long-lasting cast augmentation for immobilization. This is the X-ray of the post-operation with the bone trap. They use the composite bone trap from the synthetic bone trap and auto iliac bone trap together. And after 1 month, we can see the healing is better. And after 2 months, we can see the healing better. And the patient have the partial weight bearing. And here is the X-ray of the 3-month bone operation with the bone trap. We can see the callus formation here in the AB view. In the lateral view, it's not quite good, but the patient have no pain and partial weight bearing now. And we change to the submental phrase and do the injury, the rehabilitation, and the patient can injury the weight bearing. So in conclusion,
sir, whether this interfragmentary screw was working or not working?
Interfragment screw is not working. So
it was on the edge almost, I think.
Yeah,
it was not
it's loosened.
And the purchase of the proximal fragment into the distal fragment may not be the accurate part.
Right.
Dr. Tanna will comment on this, I'm sure.
Yeah. Tanna sir?
Yeah. So it's
a very short oblique fracture.
Yeah.
And so if that you're not going to really any effect on the leg screw there.
Yeah.
Yes.
So do you have a final X-ray they did held up, doctor? Do you have the final X-ray of this, of holding up?
No,
because up till now 3 months it is not held up.
Yeah, this is the patient just 3 months follow up, not finished yet, and continue to follow up. We don't have the final X-ray. The patient continue to follow up because this X-ray take in May.
Okay.
Yeah, this X-ray just take in May.
Okay.
Yeah.
So now yes, please carry on, doctor.
Yeah. So in summary, the SIGN-GOA is an excellent option for management of tibial and femoral shaft fractures, especially in the hospital where do not have the C-arm available. And correct choose the nail size to optimize the stable construct, and dynamization the nail in case of trophic non-union, and the level of weight bearing depends on the fracture patterns and the stability of fixation construct. Thank you so much, and thank you, Dr. Zirkle.
Thank you.
I'm sure Dr. Tanna will not agree with the word dynamization in atrophic non-union unless you do singling and put lots of bone graft. Am I right, sir?
Yes.
Actually, here I'm not mentioned about the atrophic. I mentioned about the trophic non-union. The trophic non-union. That means a loss of vascularization of the bone, but not the stable fixation or the gap still in the fracture side. So then we can do the dynamization and maybe not need the bone trap.
All right.
If I can summarize for this, the way it is different from the normal nailing which all of us are doing today, that this can be done without the C-arm because of that sleeve and that everything. It is basically, that is the main benefit of that.
Yeah.
Am I right?
Yes.
Otherwise, it behaves the same way like all the other nails which we are doing. This is a solid nail.
Yeah.
Yes.
So there is going to be a little less flexibility.
Yeah.
So there is not going to be that small flexibility of a hollow nail, which we have it in the conventional nail.
Yes, sir. I just want to ask that since they are not using C-arm, how many times they have to use portable X-ray machine inside the operation theater?
We don't need actually to use the portable X-ray, because most of the time we can be sure with the slot finders.
Actually, in my country, for the safety of the final result, even during the operation, we don't use the C-arm to check. But for the final locking, we always check with the X-ray. Check with the X-ray before we close and terminate the operation.
Okay.
So one last question.
Yeah.
Yes.
So for the reduction also, you don't require that X-ray plates or one sort of APN lateral. You don't check in between.
Normally, some difficult case with the drop lump with the reduction, or some difficult case we cannot find with the distal fragment. So we also some case we need the X-ray.
Okay.
In a femur also the same way. In a femur, you don't use the C-arm.
It's different. In femur, it's different, because in femur we don't have the orthopedic table. So most of the case we use the open reduction. And for the interlocking, screw, we also use the zig, and we can feel. Even in the femur, we do the interlocking screw application with the a little bit larger incision. Then you can see a little bit the slot in the nail. You can see by eye clearly in some cases.
Good.
Okay.
Yeah.
Thank you.
Okay, so the femurs are open. Femurs are the open reductions.
So the reduction, are you comfortable with doing the open reduction for the femur just because you want to do a sign nail? If you have today's modern, all the gadgetry available, we all know that if you open the femur nail, the healing is going to be affected.
Definitely. If in our hand we have the enough facility, like we also have some modern nail, or some other hospital, they have the orthopedic table, and they have the cannulated nail, so with the C-arm, so they can do the close reduction. For femoral, not 100% cases we do the open reduction, especially for the distal third femoral shaft fracture, and we do the retrograde method of the side nail. We can do the close reduction and close nail fixation.
All right. Next.
Yeah.
Thank you.
Okay, Dr. Antao, your case is there as per this presentation, sir.
Dr. Singh is not there. Dr. Singh.
No, it's your case. It's TBR
It's
now.
your
So
case.
it's
Then
your number.
Your number is there, sir. And the case double B has selected is case 1.
Double by. Can I share my screen?
Yeah.
You can. Navin bhai, let Dr. Antao share the screen.
Yeah.
So
100%.
okay.
Select the case 1, sir, if it is possible.
No, now okay. So while Dr. Antao selects the case, this thing, is the lesser incidence of nail breakage, and then is extraction a challenge because of solid nails?
Yeah, actually, we get a lot.
Yes, Joseph.
All right.
Yeah, those are some of the challenges we get. You get a broken nail, and removing sometimes it is difficult, but it depends on the point where it was broken. But most of the time, the nail breaks, like for the tibia, most of the time find that it breaks near the fracture site. So it needs opening, then tracing the end of the nail. Then you have to remove the screw then you can use any instruments to hammer that nail out through the entry point. That's for the tibia. Sometimes it breaks in between the two distal screws, those two dynamic holes. So that one, it becomes a little bit challenging, because if the nail it breaks at the distal, that means you have to get away. Sometimes I remember there's a time I had to do a bisection of the distal fragment so that I could get the piece of the nail out.
Okay.
But for the femur, it's the same thing. You look for the entry point and remove it, whether it was retrograde or antegrade. You can use whatever you have in order to remove the nail, but it is challenging, especially when you find the nail was bent.
Thank you, Joseph. We hand it over to Dr. Antao now.
I'm presenting a case of a vehicular accident in a 24-year-old man who came to the hospital after 2 days. The fracture was very close to the articular surface, and he had a lot of blisters and early compartment syndrome. So what do we do? Can you hear me?
Yes, we are all able to hear. It's a very short distal segment.
Yes, for me, I always do under nailing in this. Once I know that these are the fractures where even such a small fragment, a good fanning is possible once you pass one nail inside the medial malleolus. It is possible in such cases as well. So when there is so many blisters and the skin tissues are not good.
How long will you wait?
I think when we know that it's not going for infection and there is a wrinkle sign, usually in a typical this case, which is not very much displaced, I can afford to wait up to even 2 weeks, no problem.
All right. I have an innovation. I do like this. Once I put an external fixator and put the patient initially, I used to do this multiple skin incisions and to decompress the beach with a stab knife, and then after that you put a mosquito and go deep under the deep fascia and open the thing with multiple holes. Now if I have a fracture upper tibia with compartment syndrome like this, I do the nailing plus the multiple holes like as we do in skin grafting, and do the nailing rather than waiting for a long time, and see how nicely they heal up after about 7 to 10 days. So I think
Antao, if there is a compartment syndrome which is proved,
yes, sir.
You fill with these small cuts and then you going down into the fascia, it will function?
I mean, it has functioned in my hands. I had never had to open it again. So it's done here, all around. The multiple puncture marks are all around, sir.
Yeah, but this is in the subcutaneous areas. Then you need to go to the fascia.
Deep fascia.
I have a question. If you do like this, you make a lot of incision. How about you not worry about the skin infection? This is it doesn't mean that we treat the bone, but we try to treat the soft tissue. Right now, you do so many skin incisions. So how about the infection?
No, it's okay. That is a point to be taken. But you see, there's no infection here. Can you see?
It's not there here. It is not here.
Right now, not infection yet, but you make not infection become the high risk infection.
In my hands, I have so far not seen when I have done this.
Okay. If I can again, sorry, I want to pin you down.
Yes, sir.
Is this then alternative of the extensive release which we are doing of the 3 compartment?
Maybe.
No.
But if you ask me, I do not measure the compartment pressure, but it's my field.
Then what are your criteria of a diagnosis of a compartment syndrome?
The tense swelling, the hormone sign, the pain.
Criteria is same for all, I think. Criteria is same for all. Dr. Yu wants to say something from the Vietnam. Yeah.
Yeah, actually, in this way, even you can decompress the superficial of the bacteria superficial compartment and lateral compartment. But how about you control and follow up the deep compartment bacterial?
All right. I'll go to next.
Okay. We agree to disagree partly, sir.
And then I did a sign nail, and this is just one screw here, and this is the function of squatting and smiling. And there's a publication from Zirkle et al. On management of distal tibia metaphysical sign nail in developing countries with the squat and smile is a good sign. If the patient can do this, that means the fracture is uniting, and on the way clinically as well as radiologically to a great extent. But they have some criteria on that some of them do not see complete union up to 1 year. This is a second case.
Sir, it was a single interlock distally, I think.
Yes. And one up.
Dr. Antao.
Yeah.
We would like to hear Dr. Zirkle on the squat and smile more details if you can.
Okay.
And there is no virus here?
Rather there is a valgus here. Rather.
But
valgus, sorry, valgus.
Valgus.
But see the function. See, rotate.
1 minute. Are you willing to accept this valgus?
I don't think it is so much valgus, sir, if you ask me.
It is mark valgus. And it is mark valgus.
And also in the anteroposterior plane also there is some change.
Some recurvatum type.
Now, to tell you the fact, this is my first nail back in 2000, where we did also have a Siam in a hospital, and this was the thing.
Okay.
I think
one
it's
thing
a good job.
One thing I would like to the audience which is there. This treatment of a compartment syndrome, medical legally will not be acceptable.
But there is a paper on this already, sir, which has come.
The one paper, which doesn't mean it is the way in which it is accepted. Then that means the whole extensive release which we are doing it is useless. We should be doing this only.
Nothing is useless. We all went from open reduction to mini open to without opening now.
Okay. I only want to put in a small protest so that it shouldn't go as if this is the treatment everybody has accepted. I haven't accepted it.
Can I have a question?
Yes.
But I have shown you the results there.
No, that's fine.
How can you share experience? How you use this is a digital fracture. So the nail go to here, easy to stress a fracture. But how your experience to share about you choose the nail close to the joint? How do you share about that?
Yeah.
You without the arm.
Yeah.
And then you use the nail, and then the nail close, the tip of the nail go close to the joint. So how do you share your experience?
Tip of the nail goes where? Articular surface.
Yeah.
Yes.
Some of them.
No, he is talking about so ideally goes subchondrally.
Yeah.
Yes.
How you could just stop going there, intra-articular? How did you be just planned it so beautifully subchondrally? Is what he's saying.
Okay, Dr. Zirkle wants to say some comment because he has raised the finger. Zirkle,
sir. The reamers of the larger nails are blunt tipped, and you can put the reamer down and it stops at the subchondral bone, and then you can measure the nail length. I think this is a good job, and we are now looking at putting a plate attaching from the interlocking screw and going proximally in some of these fractures.
Okay. Additional augmentation is planned. Okay. Now.
Yeah. All right. We'll show you that now. Can I go to the second case?
Yeah. Go, sir.
Yeah, this was the case of maluniting fracture after grade 3B compound fracture, fixed sectional fixator elsewhere. Patient came with pain, deformity, inability to walk and all. The external fixator was removed. And now what are the options left? One must remember that the skin in this case was not very good, and some would like to do a skin cover first, then put a plate or a nail. What about the bone graft or Irizaro? Would you think there might be infection?
Can we see the clinical photograph, sir?
Yeah.
Oh.
Well, the skin is not open. It has been.
See, sir.
It is healing, sir.
Healing. But he had, if you see this kind of scars, you will always say the skin healed by, not by primary intention, but by secondary. That means that there must be some sort of an infection or so. Mild or big, no idea.
So is there a sinus? Is there a sinus? Any discharge?
No active sinus now. His blood biochemistry was within normal limits. That means the CBC, ESR, and CRP. And
No. We are talking about the skin condition.
Yeah.
I'm sure there is no infection inside, but the skin issue.
It looks, inflammatory and all, but there was nothing much in terms of real this.
So it was platable and it was nailable both.
All right.
No. This is a signed nail conference, so it is nailable only.
Okay, sir.
Okay. Now I did what I did was I took a strong big incision on the inner side, and I put this nail, and then at the same time, because I had opened it, you see I have not done anything to fibula because I didn't want to get the length. I told the patient, because if I have the length, maybe it may be difficult for me to fill up the gap and all. He was okay with that, about half a centimeter to a centimeter. And then you think this will unite?
So the fibula was healed one?
No, fibula is not healed, if we can see that.
Okay. So you did an open reduction, I think, probably to get the reduction.
I had to.
Partly.
For the malunited, no?
Okay. So you did a osteotomy regularly, or you recreated the fracture pattern?
Exactly, and then send the material at the same time for tissue for high power field examination for leukocytes. When the leukocytes were less than 5 per high power field, I was able to do something. I went ahead, and I could not close the skin, as you can see it here. So this much of left, and I kept it open like that. But I was not very happy.
Yes, there is a posteromedial distraction. That gap is dangerous.
Yeah. So what I did was
How could you reduce the tibia without doing anything to the fibula?
Fibula.
He said it was not united. It was not united.
Oh, it wasn't united, actually.
No, that is the question I asked also.
So what I did was, on the third day, I went back inside, and I did put the sign plate up with bone graft, because by the time the report was conclusive that there was no infection, and I took a posterior release incision. So difficulty was to cover this plate. So what I did was, tibialis anterior muscle was there. I took a part of the muscle and fix it over the plate, covered up the plate, and then I was able to close this skin, and after this posterior release incision, which healed on its own without much problem. Any comments?
So you did a rotation plasty, something like that.
With a release incision, you pull the skin in front and
the rotation, your rotation, partial rotation flap.
This is very good, because ultimately you collapse the fracture. But did you do bone grafting as well?
Yes, Yes. You can see I have filled up the gap here. I didn't do
He
it because
he added the stability with the plate, I think, also.
Yeah. And this is what he said, final function, squat and smile.
Antao, sir.
Yeah.
So you did an open reduction on the first day, right?
Yeah.
So what was your reservation not to add a plate there?
Not to put a plate.
On the first day?
Because I was not sure about the infection.
Well, if you put a nail, I'm sure you were very sure. You were.
If there was an infection, even the nail would have created a problem for you.
Yes, sir.
Oh, you didn't use an antibiotic nail.
I purely went on the blood biochemistry, that it was normal. But, you know, sometimes your sixth sense tells you that, all right, it's better to wait, see, keep the wound open. And normally I do this.
Probably you took the decision by taking the fluid intraoperatively and intraoperatively asking your pathologist to see the leukocyte counts.
Yeah.
Okay.
Yeah, intraoperatively he confirmed that the leukocyte count was not more than 4. It wasn't more than 5 in the high power field.
Yes, sir.
So it was no infection.
Yeah.
So he treated. And after putting the nail in the possibly afterwards, when you found that the gap is there and it is not going to heal up, so as a second thought, you went down and did the plating and grafting.
Yes,
Am I right, Ant?
That's on the third day, yes.
Yeah, fine.
And that's a HB plate of sign, high visual plate.
Did it heal up? You have the last X-ray?
Doctor.
Anta, you have the last X-ray?
No, it is. Only smile.
Only smile, acha.
Yeah.
So, Dr. Zirkle, there's a question for you regarding the squat and the smile. What is the big philosophy in that as a follow-up and as a measure of outcome?
We find that the squat and smile is probably more accurate than the X-ray. I think Dr. Antao did a great job here. And we always have to recognize that stability is important in treating fractures. And we see many patients that are treated with previous infection with the nail. We are now studying the squat and smile to compare with the X-ray, and we feel that if the X-ray does not show healing, but the patient can squat and smile, then we do not do further surgery, and they usually heal.
Okay.
We're also doing this with the humerus, with a plank exercise and abduction exercises.
Babhulkar, sir, you were saying something.
Dr. Tanna says if there's a small gap at the fracture site and the patient is walking and there's no pain, don't worry, it will heal up with time. And this is exactly this article says that at 21% they had incomplete healing at 1 year. 70% it came down at the second year. But the squat and smiles and radiographic reliability had good inter-reliability and a potential to heal over time.
It's also that the squat and smile is like a follow-up without the patient coming to see you.
Yeah.
Okay.
Without the X-ray.
Okay.
Without the X-ray also.
Okay, sir. Now there are three.
X-ray is here.
Yeah.
Acha.
We have.
Yeah, it is healed up. It is healed up, Anta.
It is healed up. It is healed up. Sir, there is a sign surgeon from which country I don't know. The name is Fasi. Fasi. I am a sign surgeon. The way it is different from the normal standard nailing is the reduction, rimming, and distal interlocking. And he says that in a femur, less than 1 week femur can be reduced close. The rimmers are sharp tip till 9 mm and onwards they are blunt ended. And he had said his experience of we had 4 breakage in over 1800 cases. Removal is difficult, but mostly they break at the fracture site. That is the contribution sharing from him. I think he's from Bangladesh.
No, he is from Pakistan.
Pakistan. Okay.
Dr. Zirkle is here. Sir, Dr. Zirkle, is the rimmer one piece or it is a welded piece at the broad part and the thin part?
Is the reamer one piece?
One piece or
the reamer.
It's the same reamers for femur and tibia. They're one-piece reamers.
All right.
Okay, okay. So the reaming part requires hardening. Technically, it requires hardening to get a good reaming edges there. So
okay.
What we get in the old design is a welded one. The tip is different and the shaft is different.
Can I go for the third case?
Yeah, you can go for the third case, but I have one question to Dr. Zirkle, sir. The plate here used, how it is different from the routine plate?
The screws aren't locking. The screws don't lock into the plate. The one aperture fits the interlocking screw, and the others are 3.5 screws, so they can go around the nail. I think Dr. Antao did a great job there.
Yeah.
Thank you.
Okay, go ahead, sir. Go ahead.
Old man with a long history of the fracture. He had a fractured upper third oblique comminuted with fracture head of fibula. No nerve palsy. What will he do in a situation like this? We will plate, locking plate, but this was somewhere in 2002 when locking plates were not there.
Okay.
All right, the surgeon did interlock nailing, old system of nail, good alignment, but is it going to join? Comments?
Okay, some valgus is there, but alignment is almost good.
It should join because it's a proximal third with a good vascularity and good contact all around. Necessarily, it should join.
But then the weight-bearing line passes on the outer side, and there's a combination.
Yeah, there is a valgus, some valgus, and some translation is there. Yeah.
So, can I go next slide?
Yeah. Go ahead, sir.
So it did not join. It's broke.
Okay.
Nail broke below the Herzog band, going into non-union. 1 year already has passed, so what's next? And you can see that the head is already united.
Okay, and here fibula was not fractured.
Yeah.
Okay, go ahead, sir.
Now fibula might act to join, to prevent collapse of the fracture.
Yeah.
So somebody, he went to the second surgeon who convinced him about another surgery, and like what Dr. Tanna said, he put a long plate, and together we
Don't put this plate on my name.
This is not absolutely right plating.
This is not what I would do it.
I said, as you say regarding the long plate, I like your tone of the voice. Long plate.
Long plate.
Yeah, that's what I mean. So that plate also broke, and then he went to the third surgeon.
Okay.
Third surgeon advised him to remove the plate, but the patient was not happy at his place, and he went to the fourth surgeon who was able to convince the patient and relatives about the importance of another surgery. Now, what will he do at this stage?
Nail and a plate.
Huh? Another
nail and a plate and a graft.
Nail, plate and a graft. All right. The surgeon thought like this. He put a T plate, and he thought that the fibula, intact fibula, was coming in the way, so he cut the fibula.
No. If he has cut so much, he has used it as a graft. You don't need to cut so much.
It is seen there. It is seen there. It is inside the tibia.
It is inside. It is seen there.
It should be there.
It is used as a structural graft.
Yeah, it
is a structural graft.
And probably this is a dangerous area to take a graft.
And also now the plate is short.
and the fracture of the fibula and the plate of the tibia is at the same level. If he had to take a fibula, he should have taken it lower down.
Yes, sir. So what do you think? It also broke again.
Now, till the time you come into the picture, is not going to heal up.
That's for sure.
So tell us when you came into the picture.
Yeah, pardon me for using some words that you use, because we are used to your webinars and teaching so much. So you always say, I inherited the patient at this stage.
That's right. That's
not all. Can you imagine? Patient was all fed up with multiple surgeries, not willing for surgery unless you give 100% guarantee. So what will you do? You said plate, nail, and graft.
Yeah.
So I removed the plate, did sign nailing with massive bone grafting together with composite graft and shingling. No locking plate were available that time. Prayed a lot, which I always do. And this is the result. And this is
lucky.
You can see it exactly. Nice.
So, no, that nail has a different angle locking also. That nail had a, I think one screw is at 45 degrees. Can you go back, sir?
That may be a broken piece of
previous.
Okay, it's a broken piece. Okay.
You see,
Okay.
And this also is oblique because you see condyles in a different. It's not.
Yeah.
A very good fixation.
Very good alignment has got very good.
If I can say, Antao,
yes, please, sir.
This is a good nailing you have done.
Yes, sir.
But has it something to do with the sign nail? Any other good nailing would have worked or no?
It's a magic stick. It's called magic stick.
Okay.
I think, sir, in their website they have written it is a sign metal which heals. So maybe something with metal also they may give some highlight on that. What exactly they are doing for the manufacturing. And I just wanted to know, after this many surgeries, what was the knee range at the end?
What was the
knee movements?
Why the knee should be affected, Jawar?
Because
unless there was a plaster. There was no plaster.
No. The problem is that even initially the first time it was failed because of lack of compliance. We have to think of either surgeon has not explained very well or other patient has not followed. Otherwise, usually these are the patients who are so in much hurry to walk and they go on multiple, not in all cases, but there are few cases. But I just wanted to know, since she has gone through this proximal end with these many surgeries, was there any problem with the knee movement or not?
He did not have much problem in the upper part, except because he was 70-year-old. You can expect some amount of early symptoms of osteoarthritis, and not being able to walk for some time, it adds on to that the articular cartilage becomes slightly thinned out. And those days the regenerators or Cartesian and other drugs that we use for regeneration of the cartilage are not
usually proximal tibia, it is not a problem knee movement. It's a distal femur is always a problem with the knee movement.
That's right.
I also just wanted to know, since patient said 100% guarantee, did you give 100% guarantee?
He said he will use sign nail, he said. Well done, Nicholas. Thank you.
On the stamp,
very well done.
Antao gave it on 100 rupee stamp paper. Antao sir.
Thank you.
Zirkle sir, there was a question from Dr. Jawar Jetwa that is it the same 316L LVM or it's a different metal?
It's 316 stainless steel.
Okay, 316L or LVM. Okay.
Now it is also using L, or now you are using LVM?
So to reduce the cost, we have to use 316L. If you use the 316 LVM, the cost will increase.
That's true.
We also are FDA approved, so we have to follow their guidelines.
Yeah, sir. Yeah.
Navin, we can have Dr. Singh now next.
Okay. Yeah. Dr. Singh's, okay. Can I stop temporarily, sir? Antao sir?
I'm just saying, this is a paper from Zirkle from 20th January 19, which they have analyzed 14 studies, meta-analysis. 14 studies, 47,169 nails, where the malalignment was 7.1%, delayed union 6.8%, infection 5.9%, hardware failure 3.2%. Okay?
Okay.
All right.
So, Dr. Antao, in this 40,000 nails, what is the follow-up percentage?
follow-up percentage. That
did they have the follow-up of all the 40,000 patients, or you have only 20% follow-up?
AJ, Dhawal, you are not supposed to ask a difficult question. Okay? Proceed further.
He has compiled all the things. That's why he's asking.
He is quoting the literature.
He is quoting the literature. And the mal alignment, I think it is a property of the surgeon.
No, it must have been a very good follow-up, because Zirkle has already said that it was a database on which they are so happy. So they must be using so much of energy to keep that database.
They are keeping everything available to them. Everything.
But the papers say that it's not. There's only the best follow-up is still not coming up to more than 50%.
It's 40.
Okay.
45.
So there are challenges to follow-ups also in low-income countries. Okay.
And it is also, as you know, in our country we have a problem in this poorer people to follow up because they change the address and everything. Okay.
So even our first study, if somebody says 100% follow-ups, you have to really doubt that paper.
Okay. Dr. Ramesh Singh, are you there, sir? Please. Dr. Ramesh Singh.
One thing I must say, Dr. Dhavalbhai, every X-ray, pre-op, post-op, and follow-up has to be sent to Dr. Zirkle.
I agree, but that's the immediate post-op. If you read that paper,
later on
ka baat karta hai. Antao sir, if you read that paper carefully, the rest are they are not compulsory. You read that paper.
No. The comparison is here. The catch is here. If you don't say send the follow-up X-rays, you don't get the nails.
Within 6 weeks, at least.
I think that paper particularly mentions that it's still challenged. It's still challenged.
It is challenging, and you have to maintain at least 30% 6 weeks follow-up to get your next supply. And
after 6 weeks, the fracture doesn't heal up, no?
No,
6 weeks is too early for that.
That is the first follow-up.
If you ask Joseph, he will tell you that how difficult it is to get back the patients to follow.
Very difficult.
Okay. Follow up until the fracture is healed.
Yes.
And we usually get it. And if they can't send in, we are getting increasing follow-up because we are testing the squat and smile picture and the other clinical studies to evaluate healing, because many people cannot afford to come back to their hospital of surgery.
That's the question. Yeah.
Now there are 2 or 3 inputs from the science surgeons of the different country. Dr. Rajiv Mahajan, science surgeon from the BPKIHS Dharan at the Nepal, he says to Dr. Antao, squat and smile is a reliable but has a low sensitivity, that is 11%, and specificity 85% in the predicting healing at the 1-year follow-up. At the same time, he says, so unable to squat and smile is a good predictor of poor outcome rather than able to do so is a good outcome. He says it is either way. So again, Dr. Fasi from Pakistan is saying that ability to squat and smile is a very efficient prognostic tool. Squatting needs full range of movement, hip, knee and ankle, also pain-free, needs fracture to heal. Patients who can squat mostly end up in the fracture healing at 1 year if the radiographic are not encouraging.
True.
And, so these are the findings they have shared to us.
That paper, if you read through it says exactly like that. But I have taken just the synopsis of the results of that paper.
But the Dr.
I think when you really think of it, if he can squat and if he can smile, unless the fracture is held up, he will not be able to do that.
Yeah.
That's fantastic. Yeah, that's true.
That's true.
So that is a real clinical outcome picture.
I think the specificity to go on a lighter tone, maybe there can be a smile on the patient's face, but is there a smile on surgeon's face or not?
Yes. The happiness of the patient.
Dr. Ramesh Singh is there, sir, or not? Dr. Ramesh Singh, are you there? I am not able to see you. Hello.
We can take the next one on, and then we can maybe when he logs in.
Okay. Then I'm going further. Yes. Dr. Turfot.
Dr. Pot. Dr. Pot from.
Dr. Pot, please share from your. I think we are not having your case here. So share from your computer, please.
Yeah.
I'm stopping the sharing so we can see each other's face very well for a few seconds.
Okay.
Dr. Pot covers another hospital about 200 kilometers from the capital, Phnom Penh, which is a lovely hospital based by a German missionary. Can you? And that has lovely theaters and all facilities, but also has, you know, the signed nailed instruments, and they cater to a lot of rural patients. So I had the experience of seeing that.
Yes. Now at first I would like to thank you, Dr. Zirkle, and thank you all participants here. So I appreciate a lot about your share about the experience, the own experience, and I appreciate. But I want to share some my topic about the nail, the side nail in femur sash. Mostly I share about my experience, and also I teaching the resident. So do you see some my?
No, we are not able to see because you shared your inside only. Just click the green button at the bottom 6 o'clock position and share the screen where we all are seen, sir. That is the good tip.
Okay, here. Yeah. So.
No, you haven't done it.
You have not done it. But just pick up that screen, and then the right side lower there is a share button. You have done it. You have done it in the demo, yeah, sir.
Yeah. So you will stop another screen share. Do you want to continue? Yes. Okay.
Yeah.
So now you share. Are you see?
Yeah. Very well, sir.
Okay. So I want to share some my experience with the side nail and femoral sash fracture. The first, I teach my resident, or I start to do the side nail. I check how to choose the correct nail, the length nail of the nail, the length of the nail. So I have 4 choose. One, I depend on X-ray. Second, I measure from A6 to suprapatellar hole and minus 5 cm by non-injury leg. And then another one, I measure from great trochanteric to suprapatellar, but no minus anything. And third, I double check during my surgery. I double check during my surgery, and after that, I collect all of the data post the X-ray to compare the nails I use it, or he fit or not fit. This is for my experience to how to show accurate length of the nail. I cannot pass it.
Just click on the screen that, and then click it.
Okay.
Click once, second time click, it will go. Next slide.
It doesn't
go. Click on that slide. Click on that slide. Just click on that slide.
Oh, okay. And then I want to share about the trick in entry point. This is the theory. You know, they say that the entry point, the theory, they say that's 1/3 posterior, 2 in here. This is the good to avoid of the hoop stress. But you know, I think that this is for the experienced surgeon. It is easy to find 1/3 posterior. But for the young or for the resident, when we teach how to correct the 1/3 posterior, sometimes it's difficult. So sometimes I have some my trick, but Dr. Zirkle can correct me or not agrees with me. So how my trick about the entry point? The first, by my trade practice, the first I have to rim intramedulla canal fits the side of the nail. So how much I need 10 or 9. I rim it first. And then I put like this. Second, I choose the 3.2 millimeter drill bit or pin, but I put in insert to lateral intramedulla wall and then a gentle tap. Sometimes it comes through also the piriformis fossa, and sometimes they come from the middle like this. You will see here. I will show you. I don't know you see or not see.
Yeah, okay, we are able to see.
Yeah, here you see here when we come out, but I put it in the posterior in the lateral like this. Rim first and put in the lateral and then goes and then like this.
So it is open reduction. It is open reduction.
This is open reduction. I for the female I never do the close because of the muscle.
Okay.
The big muscle. So when he come, when he come here, so I feel it. So I take the resident, or I teach, or I do myself. I use the oil. I use the oil a little bit posterior here, a little bit posterior. This is my experience. So the strategy I do like that. Okay. And one more. Why we are challenged with the digital lock? When I have the digital, I teach myself or I teach the resident. I say that you have to check the entry point. Do you think you do it in the right of the entry point? Is the entry point you do it so good? You have to check your rimming. Sometimes you not rim the whole of intramedulla canal, or you miss some part. Why like that? Example for the I will show you. For the transfer fracture, you rim it, then we cut the whole thing of the canal. But for the oblique fracture, I show my resident. Oblique, sorry. Yeah, the oblique, when you put the rimming, you never rim this part. You only rim from here to the proximal or distal, but you never rim this part. So when you put it back, like this, and then you put the nail, and sometimes the nail not in the center. So I teach myself, I find it myself, I teach the resident, please, to avoid that, you have to reduction again, and then rim it from the proximal. Rim it from the proximal. Don't miss it. And then, and about the locking, this is, I come by, maybe I come. About the locking, the digital locking, I think depend on the use the nail. When you choose the nail from the female, when you choose usually you choose on the supra of a patella, the nail go a little bit anterior. Sometimes the nail never go with the target aim. Sometimes he no go with the target aim. So he move. Sometimes he move a little bit anterior. But if you do the nail to the condyle of the female, he more come to the center. But most of the surgery, because we are afraid go to the joint, we never go to the condyle. Sometimes we go to the center of the a little bit epicondyle or maybe supracondyle. So this is the if you go to the deep, maybe he go to the center. About the locking, I thank you so much about you sharing about the finder, slot finder or something. But I find myself, I drill the near cortex. Before I drill it, I have to decide first. So I go to the center or I go to a little bit anterior. But most of the case, I go 2 millimeters to the anterior. Even the target aim, he go there. And then you can use the slot finder, but sometimes I drill in big. I decide to drill big already, and then I use this. I not find I not use the slot finder, but I use the suction tip. I suction tip and then I feel with the tip, and then I go with the line. I go to find the slot. Yeah, the slot over here, with the suction tip. So when I go there, I put the slot drill and drill to the far cortex. So most of the case, I never miss the locking. But some of the case, you use the slot finding, sometimes it doesn't go inside. And be feeling go in, but doesn't go, and then he misses the lock. But for my case on X-ray here, with the fragment like that, yes, I never to reduction there, to anatomy reduction. Oh, no. But sometimes I use the suture, one polysorb or two polysorb to suture on the fragment like that, and then I try to push it to close as possible, but how to gentle, not periosteal anything, only one suture and try to suture to tie it. This is my experience with the side nail of my practice. Thank you so much.
Thank you.
I hope Dr. Zirkle can correct me.
So, Dr. Prof, I have one question.
Now?
Yes, please, question.
Yeah, one question. So with the femoral you show for us, so how can you control the alignment up the left, and you did the patient in lateral position or supine position?
Lateral position. Lateral position alignment. We have to find. Sometimes the fracture easy for us to find the fracture line, but sometimes we have we cannot find the fracture line. We have to find the border of the bone.
Yeah.
Okay.
You have to fill the border. Then
you
fill
the border.
Dr. Babhulkar sir wants to say something. Yeah.
Is it necessary to do the open reduction of the fracture shaft? He has suggested every fracture he opens up, does the retrograde rimming, and then he does the regular rimming.
Yeah.
I want to say you this is I don't have much experience about retro nail. Why? I do some most of my case I do with the side nail with anterograde because I don't like retrograde because the poor control infection. So yeah, if the good infection controls are good, I think retrograde.
Sir, the question is not of the retrograde nail. Question is you are opening up all the soft femur fractures for doing the reaming in a retrograde way, and then you are putting antegrade nail. Question is not about the retrograde nailing. Have you be able to do a close reduction or not? That is the probably question of Babhulkar sir. Am I right, sir?
Okay.
That's right.
Yeah.
We should use some different joystick method to achieve a close reduction, which is possible.
Yeah. I know experience about close reduction because this is with the big muscle. I don't want challenge with but I use the C arm. Okay, I use the close reduction, but without the C arm for the big muscle, I never tried. Waste my time. Thank you, my experience.
Okay, Dr. G S sir has joined again, and he has some input, sir. Please, sir.
No, I want to know how much infection case after the open reduction. How many cases he has open reduction?
Okay.
And how many cases infection he had?
I want to tell you about the femur. I do a lot. Most of the like one person or 2%, but very rare because I am very strict about infection control. Like I not trust I not open wound. It doesn't make the infection, but the poor control makes the infection. And then I check during I do surgery. If I do the clean room, I never let my staff go to the infection room, come to my room. So I very strict about the infection control. I not try about the closer open. Yeah. But I think the closer better. But the wound when we surgery, the clean wound, I don't trust that this is the major infection.
Okay, Dr. Jawad Jetwa wants to say something. Yeah.
I just want to give a tip that regarding the length of the femoral nail.
Yes.
I have shared the link from the tip of the elbow to the distal interphalangeal joint of the ring finger, little finger, is a good size. So you need not go worry about that. Once you put that size, it coincides.
Yeah, I want to share this experience. I don't know, but this is Dr. Ram Kamsas and Dr. Singh share about this when he come to Cambodia. I try to do it, but it doesn't fit.
No, no.
I don't know. It doesn't fit. No, my experience. So before that I have to check it, but it doesn't fit. I don't know. I don't know about that. But if you go there, maybe I really miss. I not miss because I checked 4 times. I checked 4 times.
The point which has been now redefined is from the tip of olecranon to distal interphalangeal joint and not the tip of the little finger. So I have shared the link which has been published.
Yeah,
and that
Dr.
link I already have
Dr.
shared.
Jagat Bhatt has published it, and Dr. Jagat Bhatt had done
Yes.
this study in the VS hospital, and he has already done his thesis on that, and he has published it. Yes, sir.
Yeah, Dr. Ram Kamsas and Dr. Singh said this about me, but I try to do it, it doesn't fit.
Okay.
Sir. It doesn't fit. So I go back to my X-ray, A6, Trojan therapy, and double check with during operation. So this is the accurate of the lab. But
We go next to the next.
Okay, Dr. Joseph, I think you can start, and probably you have given a link to Dr. Kennedy, so he has also joined your friend. I think so.
Yeah,
I can see that Dr. Kennedy has joined, but he has kept his mic and the video both off. Probably is your friend, so he wants to see you very well.
Joseph.
Yeah, thank you very much for.
Yes, I'm just around.
Hang on.
I want to share my views also.
Okay.
Thank you for good observation.
Okay, no issue. Let him complete. Then you can. You are our another guest.
Okay, sir.
Joseph, you must tell them about the border vehicle that you have in your place.
Yeah, exactly. So I'm Dr. Joseph, working with the Mumbai Orthopaedic Institute. It's one of actually it's the largest trauma center in Tanzania. And it's it's a teaching hospital where we share the department with the neurosurgical department. And it's a 360 bed capacity. And we have now 10 operating rooms. And it's located in Dar es Salaam. This is it used to be the capital city. And it is approximated to be having like 500 million inhabitants. And I should tell you the truth that 80% of our patients are from motorcycle crashes. And this, we call it a leading center in using SIGN in Tanzania, but I don't know about other parts of the world, but you'll see later, and Louis, I think he'll tell you something about the volume we have there. Next slide. Okay, so this program in our country, it started in 2009, and to date, we have operated 7,142 cases. These are the patients whom we have treated, and we are making a close follow-up. Then most of the time, it's an average of 10 cases per day. That is including emergency and elective surgeries. But there are some peak seasons where you can operate even up to 15 or 20 cases in a day with a very excellent outcome. And I remember the first time when Louis came to our center, he had a motto that observe one, assist one, do many, and teach many more. And this is our motto. We have been having it. So we have been teaching our juniors. Even seniors who wants to learn, they always come and we teach them. So that most of the centers now in the country, in different regions, they can do SIGN. So here I've selected some few cases, and this is very interesting because one type of nail can deal with the different bones and with different fracture patterns with a very good outcome. And as earlier on, my colleagues presented that squat and smile is the key sign of success for this nail. And I'm a witness for that. So case one is that we had a 30-year-old female. It was a motorcycle crash as a passenger. And she was a polytrauma patient who was stabilized. Then later on, we found that he had a ipsilateral right femoral shaft, but cervical and acetabulum fractures. So this patient was optimized for surgeries, and we did stage surgeries. And the first surgery we did was the reduction of the neck fracture together with the acetabular fracture fixation. Then after 1 week, we went in again and we did a retrograde SIGN. Next slide. So this is immediate post-operative. We did, as you can see, the hip screws with 3 screws. Then we fixed the acetabulum. Then later on, we fixed with the nail, and this was 6 weeks post-surgery. But unfortunately, I could not retrieve the squat and smile photo for this patient, but the patient is fully weight-bearing and went back to her normal activities. So this is the end of the first case.
Do you have a difficulty in measuring the length of the distal screws? Probably here the screws are little coming out on the medial side in this case. How do you measure it exactly?
Yeah, exactly. Sometimes we get difficulties in getting the screws, or sometimes if you look at this X-ray, I think that is acceptable. I think it's less than half a centimeter. So that one is somehow allowed. So there's no difficulty so much.
Okay. Fine.
What is there in the proximal screw for the busy cervical? There is another small white impression, which is what is there just medial to the screw head?
That is a plate. That is the acetabular plate.
No, the superior screw.
Third screw.
Yes.
These are 3 screws.
So what is it? There is impression, white impression.
Yes. What?
This one.
Yeah,
yes. What is it?
That's a third screw.
That is the third screw. Probably it is from the anterior cortex, so it is short.
Exactly. We are missing one image, the axial view, which could have shown us.
Here we can see. Here we can see.
Exactly.
Here we can see but it is starting from the anterior cortex. That's why it is here. We can see shorter.
Yeah, exactly. I think those
there is no true lateral view. Otherwise, we would come to know. This is just like physial separation screw, anterior cortex, typically.
So there's a lot of callus at 6 weeks, right?
Yeah.
Yes.
Callus is there. Good callus here.
We always encourage our patients to start bearing weight because we are sure of the fixation.
She had a head injury also, sir?
What?
She had a head injury also in a polytrauma?
Yes, this patient also had a head injury and a blunt chest trauma, but she was scoring 15 when she came.
So the callus, the amount of the callus is suggesting that possibility of head injury and that secretion of that chemicals and good callus formation. Yeah.
Very true.
Sometimes passing this proximal freehand interlocking screw may be very difficult because you must, I don't know how you got the full moon size and then you got the distal interlocking screw, which is at the subtrochanteric level.
Yeah, exactly. So with our experience that when I fix with a nail, most of the time, if there's not a fresh injury within 2 weeks, I do open. So after opening, I do what we call the rimming through. Then you fix it with a nail. But the trick here, make sure that the rimming is at an accurate or the correct size so that you don't hammer the nail. So the first thing is the stages, because the SIGN kit has very useful instruments. Because after putting a trocar, then putting a sleeve, you drill with the the neocortex. Thereafter the neocortex, what you do, you go with the broach to increase the size of the hole. Then later on, you go with what we call a step drill. A step drill is the instrument that helps so much to make sure that whether you are inside the hole or not. Now, when it locks and it doesn't rotate 360 degrees, that means you're sure you are there. So what you do, you get a cannulated slot finder and it drills through the far cortex. So it goes with experience.
Excellent. Excuse me for interruption, Dr. Joseph. He is asking, do you observe stress fractures like at this level because of the tooth?
Yes, that's very true. We get a lot of stress fractures. And with this fracture, we had difficulties because no CM at that time, so we could not approximate the exact length of the nail to kiss the screw, which was more distal, which was fixing the neck. So this was a challenge, but we always get the stress fractures so much.
And the distal is more the cortical bone. If the nail length is higher, then you get a somewhat metaphyseal region, so you get a easy making the hole in the shaft. Right.
Okay.
Okay, sir.
One
Next
of the
case.
other challenges, Joseph, is that the proximal femur with this neck shaft or with the segment are usually very narrow. And
yes,
then therefore, I think getting an unreamed nail across can be really challenging. Even a 9
very
could
true.
be.
And this distal entry nail has a curvature right and left, or it is same
No, it has
for
the,
both right and left. Does it have an anterior curvature accommodating the anterior curvature of the femur?
It's the same nail.
No,
it's
no,
the
it's the
same
right
nail
and
we use.
right and left same.
No left, right.
So it is a straight nail. It is a straight nail.
Yes.
Dr. Joseph, you must have done parallel studies since you have such a volume with the fin nail in these situations.
Yes.
Fin nails per se, you must not be having any stress fracture, and incorporation must be much faster. What is your thoughts on that?
Yeah, actually, now we have changed so much to fin nails. You'll see one of the cases which I'm going to present. We're using a lot of fin nail, and it helps us to go away from the stress fractures.
Okay, Dr. Mohammed has also one good case of pediatric femur where he has used the fin nail. Right. Okay, the next case, sir.
So the next case was a 28-year-old male. This was again the famous motorcycle crash. This was a rider, isolated segmental fracture of the femur, left femur. So this patient we optimized and we did as an emergency, because when they come, we do direct, we take them to theater and operate in the same night. So combined direct and indirect reduction, and we applied a retrograde sign nail without using SCM.
So you did an open reduction at both the sites, or a limited open reduction at one site only?
It's like I can call it a mini opening.
Okay.
What we did is to open nearly to the proximal fragment so that we could pass the reamer and control the rotation of the fragment which was hanging. Okay. So that was the only thing that we did.
So you hold that middle fragment by opening while reaming.
You did not spoil the biology of the fracture.
Yeah.
Actually, it was a very small opening, and we only held the part of the cortex which was visualized at that time and reamed through. Can you put the next slide and we see?
Yeah.
Wow. Yes. So this I could not retrieve the immediate post-op X-ray. So as I said, slightly opened somewhere at this point, and we reamed through because we never opened here. It was easily to manipulate with the reamer.
Can I interrupt, Dr. Joseph?
Yes, please.
Yeah.
Since the second screw is very close to fracture site, you think if you had to use a longer nail, it would have been better?
The issue is not the length of the nail. The issue is with the joint, because if you use a longer nail, that means the nail will drag to the joint.
No.
But this, yes, please.
Why drag the joint? You have 4 screws up and down.
But the issue is the instability. It is an infraisthemal fracture. Even if with the interlock, there is an invisible instability always. With the 2 screws, and these 2 screws are also not a bicortical. If you see, these screws are not crossed here. The opposite cortex.
Actually, this is just a poor X-ray. Sometimes you don't get a proper AP X-ray.
It is in the rotation. It is in the rotation.
Yeah, to the far cortex. Yeah, sure.
Okay.
There is a gap also there. There is a small gap there.
As it is segmental.
Yes,
it
is a gap.
That one we agree, because most of our patients, because we ream, and when reaming, that means you spread a lot of the reaming material that acts as a graft. So most of our patients, they heal by grafts. If you see the 6th week of this X-ray of this patient, you find the exuberant colors on that point there. So it's not an issue. It's just what we do, functional reduction, and make sure that we have the contact between the fragments.
Okay. So do you have that follow-up X-ray of union and all that?
This is the 4th week. The 6th week I could not get it. Our system sometimes it crashes, and we get difficult to get the X-rays. But I think I'll share. Yes.
Okay. So case 3.
Yeah. Then Another patient, you know, this is to show us that we have a lot of high energy injuries, and I do a lot of pelvis and acetabulum. So this was a 40-year-old male. This was again the motorcycle crash. So ipsilateral right subtrochanteric and also transverse acetabular fracture. So this, we optimized this young patient, and that same sitting, we fixed the acetabulum, and again we fixed the proximal femur. So I know the questions will rise that about the stability and also the gaping you can see there. The issue is most of the proximal shaft like this, the subtrochanteric, we always go through the piriformis fossa. Then before that, you do reduction and hold the reduction and rim through so that you don't get different canals. I mean different direction orientation of the canal, so that you don't displace the fragment. So again, to add stability, there are those HB plates where you could add here. But after looking this patient, we found that the stability was observed, and we decided to leave the patient the way he is with this nail.
Only issue is the proximal fragment is possibly in somewhat of axial rotation. The typical proximal fragment remains in the axial rotation, flexion and abduction, typical deformity in this level, I think.
Yes,
any input, sir? GSK sir, any input from your side, sir?
Yeah, this is a very oblique fracture and is very unstable. And possibly it may go into non-union. What I would have done is probably add a plate to this, or a surplus wire, or a lag screw. So another accessory treatment is necessary for this.
Yeah, Joseph.
I agree.
In view of the fracture acetabulum and the piriform fossa entry, do you think this patient is bound to have some arthritis with time because of the vascular disruption at the piriform fossa and the trauma to the articular cartilage because of the intra-articular fracture?
Yeah, you know, one thing with what we did is maybe I share with you how we went through Cocker-Langenbach, the patient on the lateral position. Actually, we do is more of the Gibson approach, but we call it Cocker-Langenbach. So that same incision which we use because you extend to the femur. And on the piriformis there, we don't open that much. The moment you palpate the greater trochanter, you just go with the perforator and get a perforation and rim through. So the soft tissue trauma is very minimal compared to if someone opens a big hole. So this incision, it's the one which is again shared when you open and remove those rotators during the acetabular reconstruction. But sometimes these patients, yes, they present with pain. I'm still following them up because I have a volume of like 80 patients with acetabular fracture, and most of them we found like 20% they have nails. Yep.
Okay.
You have a follow-up of this? Do you have a follow-up X-ray of this?
Yeah, this one is immediately post-op. As I said, last week our system crashed, so we lost some of the control X-rays. Maybe because of the short time and what, but I could not retrieve them. But Kennedy, I think, can get an access to the SIGN database, and we can maybe later we can get and see the cars. But this patient, I saw him in the clinic. He was working at those.
Navin.
Dr. Zirkle, can you come in and comment on this fixation, please?
Dr. Babhulkar sir wants to say something. Yes, sir.
Yeah. Is there any incidence of myositis ossificans for this fracture pelvis and subtrochanteric fracture? Incidence of myositis ossificans.
Yeah.
Joseph, the question is myositis ossificans, newborn formation because of such a long exposure and such a bad injury to the soft tissue and bone.
Yes, true. Patients always get myositis ossificans, but immediately after surgery, what I learned is that, and what I always do is before I close, because myositis ossificans also can be caused by the redundant tissues which you leave them there, which are crushed, or the which may add more fibrosis and also may favor the formation of the exuberant colors and all those factors that can lead to that. So I found that after doing surgery, debridement, remove of those dead tissues which were crushed during surgery, but the best thing is to observe the soft tissue handling. Maybe we make a follow-up. Maybe from these 80 patients, I may come up with something concerning all these factors.
Okay, sir. Can you go ahead with the fourth case? Yeah.
Yeah. The fourth case is 30-year-old male. This was sleeping in his house during heavy rain. So well fallen his left thigh. So he got an isolated transverse femoral fracture. So this patient was primarily fixed with a fin nail by my resident in the night, late in the night. So this was immediately post-surgery. So you can see the use of a fin nail. So they could get, you can see the fin nail, it has to be through the isthmus or slightly above the isthmus so that it holds there. Okay. But this patient came back after a while. When he came, he complained of severe pain and he could not flex the knee because of that severe pain. So next slide.
Okay, the only one question is, all these nails, routine interlock nails, we introduce with the rotation. Here, did you introduce with the rotation, or how much hammering you require to get a canal fit? Do you do a hammering also?
Yeah, that's very important. For the fin nail, you have to hammer it. You have to use some energy to hammer it. And rimming for the fin nail is different from the standard nail. Standard nail, you rim 2 points more, larger than the diameter of the nail. But for the fin nail, it's 1-to-1. So imagine if this was size 10, that means you rim up to size 10 and you hammer it, because those fins have to hold on the isthmus there.
Okay, at the place of the fin, the diameter is little larger than the 10, I think. At the fins, fins are compressible, yes. Or these fins are not compressible?
No, these are fixed fins.
These are fixed. They are not compressible. Fixed, yeah. That metal is compressible.
10 means the diameter of the fin is 10.
Okay.
They are compressible. You just hit the locking bolt after you put it in.
Yeah. That is my understanding, that you hammer it, it goes in and then compress, and then it gets released somewhat, and that gives the anchorage in the intramedullary fit.
That's not like that. Actually, Dr. Zirkle was telling about the compression of the fracture, what we give after putting the distal screw, we then use the ramrod to compress the fracture. That he was telling like that the fin engages in the medullary canal in such strongly that you can even compress the fracture.
So you do back slab hammering after engagement of the fins?
No, it's not back slab. It is straight, not back slab.
Not always.
Yeah. Okay. So next slide, please.
Yeah.
So
it got displaced.
Yes. So as you can see this image here, when this patient came back second week,
probably we were not having the lateral view, and this is the third fragment here. Probably that was a splintered at the time of surgery itself, or there may be a second fall, because we do not have a lateral view. The lateral view will tell us where this fragment was. Yeah, and exactly. And here the canal is very wide, so there is a translation possible.
Exactly. So that's what happens. As now this patient came with the pain, and it looks like the nail had failed. Next slide, maybe we see the next slide could be having the image. Oh yeah, sorry, we lost one of the X-rays. Okay, so this is the time now we went in, revision surgery. We removed the fin nail, then fixed with the standard side nail, and the graft was also applied. So we locked this nail with 2 screws, proximal and distal.
Okay, the distal locking is complete to bicortical, and previously distal locking was not complete, I think so, probably.
Do you think the nail is too thin?
For this one?
Yeah.
The nail which was there before, it was size 10, and here we fixed with the size 11, a wider nail.
Oh.
The previous nail was thinner.
What?
the previous nail was thinner.
Yes, it was thinner.
That was probably the reason for why it got displaced.
No, still we are not having follow-up of this also. Still,
Joseph, do you think there's some activity of lysis going up at the proximal screws?
No, I don't think so, sir.
Yeah, no, nothing. There's nothing.
All right.
Yeah. So this patient, we kept him on close follow-up every after 2 weeks. We kept on seeing him. So he came 12 weeks later, and we did squat and smile. Actually, this is my driver. He drives my children to school. So he's back to his business. So he's driving well. He has no pain. He can flex the knee. He can squat and smile. And next week we'll be coming for another control X-ray, and we see how much callus has been formed.
Why don't you go for an antegrade nail? Why retrograde?
It's surgeon's preference. It's almost the outcome is the same. For the antegrade, that means the patient remains in supine. For the retrograde supine, but the antegrade we do lateral position. But this patient, the previous surgeon had gone through the knee. Through the retrograde. So we had to use the same incision. We never wanted to go again to the proximal to start with the antegrade.
Yeah. And particularly with the obese patient, the retrograde is better for easy access to the entry.
Yeah, exactly.
Yes, maybe I can share. Here, at least we know that this is an exchange nail.
Yes.
And then putting the patient on the lateral position and taking out the fin and inserting a new nail, then you are going to damage other tissues at the greater trochanter. But it is worth to go the same way and you over-rim to get the larger nail.
Yeah.
But very unfortunately, this nail was a bit short. Yep.
Do you use polar screws?
These are all new screws. Yeah, these are SIGN nail screws.
No. He's asking about the blocking screws.
Block the canal. Yeah.
For the femur, most of the time we don't use the blocking screw. Tibia, especially the tibia proximal, the most proximal fractures and the distal fractures. Those are the ones we use the blocking screw.
Any difficulty anytime you are not able to remove the scratch fit fins from the nail, removal of nail at that time? Is there any difficulty of the scratch fit and there is a callus or inside the bone formation and it becomes very difficult to remove that scratch fit
with
fins?
My experience, what I can say is the fin nail is the 3-point fixation, but sometimes you can hammer it in and you fail to hammer it out. Technicality, we used to bisect the femur where the fins are at the proximal, and then you create a fracture to treat a fracture. For example, at this particular, if you fail to take it out, you bisect the femur, and then you release a bit the fin, and then you hammer it out. It comes out.
Do you have any such case to demonstrate here? No.
Yeah, but now it will be difficult for me to find a case.
Okay.
I need to go to the database.
That is the difficulty I found technically, that here the fin, if it is a scratch fit, then the removal you hammered a lot because to get the good fit, and then removal becomes difficult.
Yeah, very true. And if you are told to go and take out the fin, which has stayed more than 2 years, pray to God.
Yeah, and it will come out. It will come out with some bone also.
Yeah, sure. You have to take a very good soup.
Yeah.
Sure.
Can I ask Dr. Antao a question?
Yes, sir.
Dr. Antao, are you using the fin nails now?
Yeah, I have my presentation waiting.
Yeah.
You are doing routinely using, or you prefer the other standard nails?
Depending upon the medullary cavity, sir, one, and there is no sense using a fin nail when the medullary cavity is very big, because you need to lock it proximally. That's why.
Okay.
Otherwise, if I have to do, I have some presentations here. where I have done in 3-4 cases fin nail.
Okay, Dr. Joseph, go ahead. So
No,
that
no,
we have still one Dr. Sindhe sir's presentation is we are waiting.
I just wanted to see the final outcome since he is his driver. Do we have the final union?
X-rays are not there. He's able to squat. He's able to squat and smile.
Squat and smile.
Okay.
And he's driving back. Yeah, lastly, I want to share with you a 53-year-old male. This is a soldier, was a driver, was driving his family to his village and sustained multiple injuries. He had a segmental fracture of the femur, then also had a fracture of the humerus, and also we could not get the pelvic X-ray, also had the acetabular fracture. So this patient was optimized. The time he came to the emergence, the femur was firstly fixed with the SIGN nail. Then later on, we did the fixation of the acetabulum. Then later on, we finished with the humerus. So this was a postoperative image after that nail fixation on this side. But this side was later on during the follow-up after fixation of other
So
fractures.
retrograde nail was almost out from the piriformis fossa.
Exactly. It was a long nail and there was no choice. You have opened, other nails have not yet sterilized, and you have opened. What do you do? So we had to hammer the nail to that point.
No. The other point here is, Dr. Joseph, there's the combination supracondylar level. Whenever there's a combination at the supracondylar level, do not take the exact size nail, because then the problem happens like this, jutting out. So you take 2 centimeters less size.
It is less harmful to come out from the piriformis fossa and not to keep the longer length at the knee.
But since it is a segmental fracture, no?
Yeah.
It
requires a working length, so it is providing a good working length here.
It's a very good.
Yeah, exactly. Another option is to put also augmenting plate, like an HV plate again, in order to add more stability. That's another idea.
Yeah.
But very good. How much the difficult was to make an interlock through that screw here, very proximal. So very difficult to judge exactly in this region, cancellous bone. So
yeah, somehow difficult, but one good thing with that point, you can open and palpate the whole of that.
You can feel the metal around the hole with the K-wire or something, or drill bit. Yeah,
exactly.
Next.
I have a question.
Yes, go ahead, please.
You know, I heard a lot also the people is so worried about the piriformis fossa. So, for my experience, I never see the fracture from that side. So, who has the experience fracture from the piriformis side? I never see the fracture. So, please say, because the theory sometimes make us scared, but it does. But for my practice, I never see the fracture through the piriformis fossa. So who will see? Can you say our experience?
One of the reasons why the piriform fossa and vascularity gets disrupted is because you make most of these nails are antegrade, and you have to make that hole much bigger than when you put a retrograde. So the vascularity is not disturbed.
Yeah. Only problem here is the transverse screw in the neck. If there is a second fall or slight fall, then there is a possibility of stress fracture of the neck femur. That is observed in the literature.
Yeah.
Okay.
There is a possibility because you are drilled in the neck, and there is always a possibility of stress riser here to get the fracture neck femur, vertical fracture neck femur here.
Yeah.
Very true.
Okay.
Next.
And Dr. Fassi has also expressed same thing. Very true. The removal of the fin is much difficult than the removing the standard nail. So that his experience he has said from Pakistan.
Very true.
Okay.
Yeah.
So I'm seeing the audience response also in between.
Yeah. So this patient, as I mentioned it before, this is a soldier. So he went back home before we even allowed him to bear weight. The 4th week, I mean the 6th week when he came, he was complaining of pain on the right humerus. So when he stepped in my clinic,
why here was nailing was not done and plating was done here? Humerus.
Yes, we decided to put the plate because we did not have the smaller size of the nail. Because for the humerus, you have to be very careful with the selection of the nail.
Okay.
Yeah. So this man came to my clinic while walking. He was at 6th week. He was fully weight bearing. So soldiers, I don't know if whether they have low tolerance to the pain or not. So we took this patient to theater again. We did a revision surgery, a plating, and with the grafting. Next slide.
Okay. Yes.
Yeah. So this was a revision surgery, still with the same normal DCP with the grafting. And this,
but little longer plate.
Yeah, a little bit longer plate. And it was difficult also to remove that broken screw through the bone itself when we were doing the surgery. And finally, this patient came with a very good outcome. He can drive now, and he went back to his work up country. It's like 900 kilometers from Dar es Salaam. So he's working. So with a very good, excellent.
Great, sir.
Yeah, so in summary, the SIGN for us, it's helpful in these developing countries that you don't need the CM. What you need is an experience, observe the soft tissue, and also follow the principles. Then also address almost all the physio fractures of long bones. Then it has few challenges compared to the costs. And I'm happy because most of these patients I presented with acetabular injuries, the moment you fix the femur and acetabular injuries, they recover very fast and they go back to their activities. Thank you very much. And thank you very much, Louis, for this wonderful name.
Okay. Dr. Zirkle's video, 10 minutes, which was remaining, should we play now?
Well, Navin, can we do the cases and then play it again?
Yeah, okay, fine. Okay.
So Dr. Farooq, I think, is probably next in line. Thanks. Yeah, good.
Yeah. Dr. Farooq?
I'll share my, should I?
I already said here, your case is here, sir.
No, but the video doesn't run. Let him run from his side.
Okay. No issue, sir. You can go from yours. But still, Dr. Sindhe sir's case is remaining, I think. And then we can have cases from, again, Dr. Antao after the video or before the video, as you decide, we decide.
Is it all right?
Yeah.
You see?
Yeah, we can see it very well.
Yes, we can.
Video should be last.
So, thank you very much for letting me present my experience, share my experience in front of such a learned audience. This is a 10-year-old girl. I'd like to present with malunion and deformity, which was finally corrected by SIGN nail. I'm Dr. Farooq Qasim, live in Thakkar. So,
can you keep that mic a little bit nearer so that you're audible very well? That is displaced a little bit. Yeah.
Is that all right now?
Speak little louder.
Okay. So, the objectives are to understand the probable complications of a neglected children fracture. We all know that in this region, especially, people report late, so we get many deformities, and of course the bone setters, they also play a role in the society for those complicated fractures. And for the children, we have to consider the possible limb discrepancy and the choice of implant is also critical because we have to consider about the growth plates. And I hope by now you all know about SIGN and the SIGN nail and its effectiveness. So this is the SIGN nail. Rather than the distal slots, it has got a fin which attaches in the medullary canal, and also it can give 3-point stability. There are varying sizes. You can see the range. And SIGN has developed a pediatric fin nail for treatment for the children fractures, as Dr. Zirkle in his 20 minutes talk already described. So these nails are a bit different from the standard nail in that it has got one slot in the proximal end and a fin attached distally. And the slot is a bit lower so that it can bypass the trochanteric physis. And there are varying lengths and diameters. And diameters of the fin are like 6, 7, or 8, or shaft is 4 and 6 millimeter. So it's a bit flexible as well. So this is a separate jig for pediatric fin nail. You can interlock screw. You can place the screw from lateral to medial, or you can also place the screw from anterior to posterior. And Dr. Zirkle acknowledges here that about the sheep study, he already told it was conducted by Dr. Biruk in Ethiopia for studying the retrograde approach. And some of the surgeons from Mongolia already did some, and without any significant growth disturbances. And these are reported in the Journal of Orthopaedic Trauma by Cleveland Clinic surgeons. Now, my case is a 10 years girl who was neglected after fracture and developed a deformity and malunion and reported to us. We got her admitted, but she was very poor, so we didn't have, she couldn't afford the standard titanium elastic nail we could have done, but so we decided to put on brush nail after correcting the deformity. So this was the deformity at that time. So in December 2011, we tried our first correction with a rush nail, and you can see the we are using the distractor made by the SIGN. And then she didn't come. After 2 years, she came with this X-ray with this remaining deformity. And at that time, she was about 12 plus. So we decided to go for correction of the deformity and fin nailing, integrate. So this was her legs, thighs before operation. So we removed the rush nail, corrected the deformity, and fixed it with the integrate SIGN fin nail, as we didn't has got the standard pediatric nail at that time. But as she was 12, so we put on a fin nail. And you can see the deformity is nicely corrected here. And this is the post-op X-ray. So the fin nicely attaches to the cortex, and it is giving 3-point stability here. So we could complete final correction with a SIGN fin nail, and she came to us at stitch removal. It seems that she's quite happy with her deformity gone, and there is no limb length discrepancy. And we have got a video of her here. You can see her walking nicely with crutches, and it seems that there is no significant limb length discrepancy. So the patient, we followed the patient, and then she came again after 2 years with a nicely united fracture with no deformity, and the implant is in situ. So we plan to remove her nail. So this was her doing squat and smile. And so after removal of the nail, she came after 1 year, and this is the X-ray in May 2016. She was then about 14 years. So there is no limb length discrepancy, and there was full function, like she could stand and squat and smile. And we have got a final video of her. So here you can say, you can see she can walk. She can walk freely, and it seems there is no limping, so the limb length is quite all right, and she can squat with smile. Even she can sit in the prayer position. So functionally, she is all right.
Great, sir. Complete function.
Yes.
I just have one question for Dr. Zirkle.
I'm just finished.
Okay.
One more slide.
Okay.
So my take-home message is childhood injuries are many times they are neglected in this region, especially, and the deformity resulted are very difficult to correct sometimes. And for a child, the implant choice is also critical. Not many centers can, and not many people can afford the standard things. And we should try to avoid injury to the growth plates, and also the trochanteric approach of the pediatric nail. The injury to the physis does not affect the longitudinal growth of the bone. And signed fin and pediatric nails are effective in pediatric femur fracture management. Thank you.
That was a fantastic case, Dr. Farooq.
Farooq, where is the 3-point fixation in this?
As the nail was free in the canal, so you can say that there is, of course, some element of 3-point contact, like the rush nail.
My question to Dr. Zirkle, that these fins are made from the same material of a single rod they are cut in, or it is a separate thing structurally?
Same.
So the multiple cuts has been made in the metal rod.
Yes.
And they are roughened. They are nulled.
They're what?
They are nulled, roughened to get the scratch fit. The surface of that fins is a smooth, or it is a roughened surface of that fins?
Well, the fins are grooved.
Yeah.
Grooved. Okay.
Okay, I have a technical question, Dr. Zirkle. Anytime have you thought of fin at both the ends?
Have we put the fin in?
Both the ends, so no interlocking screw.
Sometimes, but usually we have interlocking screws in the near end. I want to say that our next step, as Dr. Farooq mentioned, is that we are now seeing nails placed in retrograde approach through the epiphysis and physis, and they're doing quite well. And we're following them until they've grown.
I just wanted to know, have you tested any time doing a fan, creating fan at both the ends and avoiding all interlocking screws?
I think it's not right, probably. And Dr. Antao sir, there is a request from Dr. Sindh sir. He wants to go somewhere
It is
out.
next, sir.
So can we take his presentation next, sir?
Yes.
He has a request, a small request, because I am seeing in the WhatsApp his request. Dr. Sindh sir, do you want to share from your computer, or should I share from here?
Otherwise, he will be discontinue my membership of.
I will share from my computer.
Yes.
You can share from your computer, no issue, sir. That will be better, sir. You are in total control.
Yes. Thank you.
Just make it full, sir. PowerPoint. So, yeah. Thank you.
My case is distal femur. My case is distal femur enchondroma with deformity managed with the SIGN-GOA. 16-year-old male presented with swelling at left knee in 2007. Inability to bear weight and deformity at left knee. Swelling was insidious in onset, gradually progressive. X-ray shows central expansile lytic lesion at distal metaphysis of femur with calcification and paper-thin cortex, gross 60-degree varus deformity. This is his clinical photograph. On examination, 60-degree varus at the distal femur and flexion deformity of 20 degree with further flexion possible up to 60 degree, and there is a LLD of 9 centimeter at lower limb in femoral segment. This is his biopsy report. Biopsy comes to enchondroma. Next. This is a incidental finding of similar lesion in the proximal and distal tibia. Next. Tumor curated, deformity corrected at GOA, stabilization by sign nailing technique. Corticotomy done at tibial diaphysis as both the metaphyseal ends are having the enchondroma. Next. This is a 24 months post-operative follow-up where both the sites are united and showing good callus and healing. Next. This is his follow-up at the 24 months where there is only 3 centimeter shortening is remaining. This is his 13 years follow-up showing recent clinical images. This is his gait. Twice sign nail, strong versatile implant with adequately long length available even for retrograde femur nailing. Strong interlocking bolt with thread at both the ends. For strong bony purchase even in such pathological weak bone. My second case, can you hear me?
Yes.
My second case is 29-year-old male presented with infected non-union with broken implant, operated for gunshot injury 3 years back elsewhere. Broken implant removed, pressing of fracture ends done, fixation achieved with sign nail, antigrade, antibiotic beads placed for the as there was seropurulent collection at non-union site. 6 months post-op showing good amount of callus formation with fracture in acceptable alignment. Challenging substroke non-union can even be successfully managed with this strong universal implant sign nail. This is the deformity correction. 15-year male section with bilateral. 15-year male patient with bilateral genu valgum. He was operated for tibial growth modulation with staple in past. These are the correct osteotomies and sign nailing both femur and left side tibia, showing good alignment, extremely useful implant in any situation, non-union, deformity correction, or breast compound fracture, and for multiple problems, especially resources.
Thank you, Dr. Shinde. Very nice presentation. In difficult situations, well thought of, well calculated, well managed, and good results.
Yes, very good.
So,
GSK
Navin
sir,
bhai.
do you want to say something, GSK sir?
No, I just came in. I was out. I just came in.
Navin bhai.
Okay.
Navin bhai. So we have actually had a variety of clinical material that's been presented by everybody.
Yes.
And we have not actually heard Dr. Zirkle express his view in the webinar. So maybe we could hear his impressions and then future thoughts and directions with this philosophy, and that would be really loved to hear
Yes,
from him. I
very
think those
much.
10-minute video, I think probably let's hear from him.
Yeah, we enjoyed the whole thing very nicely. It was a very nice
So
presentation.
should I play that 10 minutes video?
No, maybe let's hear him.
I think let us hear him.
Okay, sir. Let me check it.
Would you like to speak? Ask Dr. Zirkle if you would like to.
Dr. Zirkle, you want to, sir, you want to speak or you want a video?
We'd rather hear you.
Dr. Zirkle, sir.
He has not
Video is
unmuted.
ready. Video is ready. Unmute yourself, please, sir. Can you unmute yourself, sir? Okay, I'm starting the video from where we left
is
it.
decreasing. Well, that sounds really good. But this enables people to buy a motorcycle. And the motorcycle becomes the family vehicle and a way for the wage earners in the family to go to work. So the motorcycles are crowding the wards, fractures are increasing, and it's very difficult now to accommodate these. This is an example of a motorcycle becoming the family vehicle. The patients are ending up in emergency rooms. This is an emergency room, and they're not even in the ward yet because there's no beds available. And then when they get to the ward, they have to wait for operating time. So it's a difficult problem. It involves many facets of treating, and we have to look at the whole thing. So the challenge is education because there's not enough surgeons in developing countries. And so many of the SIGN surgeries are done by non-surgeons. Facilities, there's not enough operating rooms, so we want to be more efficient. In the United States, trauma centers serve that role because they treat the patients right away and they can treat more patients. Appropriate implants are important because now they have to be affordable and effective, but they have to be able to be used by non-surgeons, and we have developed implants to serve that role also. The SIGN response is continuing innovation, as we are doing, and looking with new eyes. And this is an important aspect. Proust stated this, and I'll show a little later. Looking with new eyes means looking at situations differently than they've been looked at in the past. Conventional wisdom must be proved because conventional wisdom changes with time. And we also are developing more efficient education using the internet. This is one of our innovations. This is the fin nail. It doesn't require that screw be placed through the end of the nail, as I showed earlier. They can be done in about 20 minutes, and they work very well. We're testing now the stability. We're re-looking at the whole fin nail design and results, and we are very pleased with this nail. This man, he's from Italy, went to Kenya as an infectious disease doctor. He asked for SIGN because he saw a big need in Kenya for SIGN. He was in a rural hospital. He's now done 1,000 surgeries in the past 3 years. And he's learned how to do surgery. These aren't just done surgeries. These are well done surgeries. And we are very pleased to work with surgeons like him who really want to learn and really want to help the people. He gets referrals all the way from Nairobi. We're learning from the fractures injured by conflict. This is a gunshot wound. We found we can put our nail in sooner for the gunshot wounds. They heal quicker. And why is this? Well, we asked an engineer about it, and he stated that the mechanical trauma of the blast stimulates the stem cells in the cortical bone, which stimulates healing. And this seems to work very well. So we developed a bone mill, which can grind up the bone fragments, provide the mechanical stimulation, and we're now testing this. So it's important that we use our observations in ways that can be done, and we're very happy with this approach. It works well with SIGN because we don't have C-arms, images in the operating room, and many times we have to do open reduction, and the open reduction gives us the opportunity to get the bone necessary for the bone mill. We also want to treat the people in rural areas. This is in Myanmar. The patients in rural areas have severe fractures and they can't get treated, and it really is almost a death sentence for them. They go home to die. This is run by Dr. Ong, who's holding the suitcase, and he travels around rural areas showing the surgeons how to do SIGN surgery, and they continue to do that. And now he's requested another set because this is a very popular program. They communicate by Facebook and WhatsApp, so they're using the latest internet technology also. So as you go through your medical school, you may wonder why you have to learn different aspects and different disciplines such as biochemistry and microbiology. All of this will come together later on when you decide on your specialty. And I didn't realize this until recently when I travel. I can remember things back to medical school which have been very helpful. This young man epitomizes our model. Education. The surgeon was educated in Tanzania, and he returned to help people in South Sudan. This young man is blind, homeless, starving, and lives in South Sudan. I don't know how you could get any lower than that, but he got hit by a car. And the surgeon, Mapur there, paid for his antibiotic, treated him, and he's standing one day after his fracture. So at least he can return to moving around looking for food. This young girl is the mother of 3 children, and she's pregnant. Her husband killed in the war. She was up in a tree to get leaves to boil because they were starving, and she fell. She fractured both of her femur. Mapur, who's standing next to her, put in 2 thin nails, 20 minutes apiece, and she's standing one day after the surgery. So we're able to help many people, and this is what keeps us going when we hear these stories of patients that have been helped. This young man, as in the rickshaw drivers throughout the big cities of Bangladesh, was sent into the big city by his family out in the rural area, and he sends his money back to support his family. These rickshaw drivers have a lot of accidents, and therefore SIGN is used to help them. We're very happy that we can do that. Incidentally, these rickshaws are very difficult to drive. They only have one gear, and so these young boys really need to be commended. An injury affects the whole family. The father was injured. These are the three kids and the mother there, and WHO statistics state that the family spirals into poverty for 3 generations after a wage earner or parent is injured. And this is a very important aspect, that we can treat the family as well as the patient. This is one of my favorite pictures because this young man in Myanmar supports his parents and his siblings. He broke his femur, and here he is squishing noodles 2 months after his surgery. It's an excellent result, and I just love to see these patients back to their former occupation. Our SIGN staff is wonderful. We all work together. They're coordinated by Gene Dillner, and we all work together toward the same goal. We're like a big Venn diagram. This is our last SIGN conference. You can see the SIGN surgeons, and they're very avid learners, and they talk among themselves and they share ideas among themselves, and it's really fun to be a part of that conference. The way forward is that we have many decisions to make when we're doing surgery or when we're seeing a patient in the office. And one of these is when to intervene in the healing process. This fracture is a failed plate, and by the way, we see many of these, and we wanted to give him the best stability we can. Well, this was done by antegrade approach, but we favor the retrograde approach for these distal femur fractures. In fact, we use the fin nail. But this was done post-operatively, and this is how he looked at 6 months. It looks like a non-union. But on the other hand, he can squat and smile. Those patients now, we wait. We don't intervene on, and we find that most of them go on and heal, as this patient did at 12 months. So this is important to tie in the clinical as well as the x-ray, and it also works well for us because many patients have been operated on and they live a long way from the hospital. They live a long way from the hospital, and so they can send a picture of themselves back in squatting and smiling, and we get some feedback that way. We're also making better implants. This is our fin nail. The fin nail, as you can see, does not require a distal interlock because the fin embeds into the side of the canal, but the nail also provides 3-point fixation. And this works well. We are studying this to look at the indications for using the fin nail, and we're finding that they are increasing. When we first started using the fin nail, we suggested it be used only in stable fractures, which would be transverse fractures. And we wanted the fin to end up in the isthmus of the femur. Okay. Our SIGN surgeons gradually expanded these indications. So now we are assaying how stable it is for comminuted fractures. Humerus fractures have also been treated with the fin nail with very good results. This patient, which we'll talk about later, is a 7-month post-op. He's healed well. And look where the end of that nail is, where the nose is, and look at the motion of his elbow. We still need to work this out, but it's this idea of using the fin nail and the humerus is working very well. These fractures are difficult. The subtrochanteric fracture often slides into this deformity, and also the implants break. We weren't satisfied with this, so we added a plate to the nail. like this. We attach the plate to the interlocking screw, and this has provided excellent stabilization so that the patients don't need further treatment, and the results are very good. We also have modular implants. That means that we want to be able to accommodate different shapes, different fractures, because the hip fractures are very convoluted many times they're different fracture lines, and we have to accommodate different sizes of the people around the world. Our goal, therefore, is for these children to grow up, and if they have an orthopedic injury, to be disabled as least possible amount so they can live happy, normal lives as they're living now. Thank you very much.
Thank you, sir. Thank you very much, sir. Fantastic points and video. Yeah. Equality of the treatment throughout the world.
Navin,
yeah.
I want to ask one question to all. Why there is in the lower end of the tibia nail, why there is a two oval windows, large ones? Is it for the putting the interlocking screws, or is it to the ease of the locking screws?
To allow
or whether it is for dynamization?
To allow dynamization.
Zirkle sir, can you answer why there is a structure of the nail where the distal locking nails are both are dynamic hole? It is for the ease for the surgeon without the C-arm to do an interlocking, or it is really meant for double dynamization? Double dynamization is possible or not? I don't know exactly.
Because there is one more above, there is one more hole. So there are 3 dynamization holes.
Yeah.
Well, when you put the screw in, you don't determine what part of the oval it goes in. And when you have dynamization, you need both compression and distraction. So it must go back and forth like this. And we're working on a plate to do that. So our nails seem to allow faster healing with this process. And I think it's very hard, but it's also easier to get the screw in because you can feel with the slot finder.
I think both the objectives are there.
I still have the same question, that since the fin can keep the rotation under control, why not the fin at both the ends? The proximal end as well as the lateral end, distal end. Why have you thought of that?
If you get a fixation in the proximal part, you cannot advance that into distal part.
No. They are able to advance since long. They are able to advance maybe after crossing the fracture.
They are able to advance when it locks at the minimum diameter of the bone.
No, the fin nail goes into the wide lower supracondylar region also. There also they have shown.
If there is
the fin nail is we first thought. Go ahead.
If there is no locking at the supracondylar region, how in a wide truncated medullary cavity, where will be the point of contact with the bone? It will be just floating there.
No, they have shown results. It is not like that. The fin also helps in catching that part as well. That is
I could not see any integrate fin nail.
Yes, there were.
They were, but in the pediatrics, I think. Not in the adult.
In the adult as well, we did some integrate nailing.
But particularly when the canal is narrow.
Yes. There it acts, it can engages in one cortex, and also there is the 3-point contracts are there. Okay. And I remember the same question arised by Professor Rizvi when Zirkle came in NITOR in our National Institute in 2003. He was drawing a nail with fin nail at both ends. Isn't that look? You remember?
Yes. Yeah.
I just wanted to think about that since you are having such an extraordinary movement across whole world with so many countries, and probably more than 20 years you are training these doctors and everything, have you thought of also an alternate to C-arm? Because that is what is lacking in the poor countries, as well as thinking of raising fund for the C-arm, and maybe the life may be more easier.
I have a saying that you don't shoot a singing bird. The fin nail is working well without the C-arm, and I see no reason to change it. You can still use it with a C-arm just as much, just as quickly, possibly even quicker, but I don't see any reason to change it. I think in the femur, which is a curved canal, you get 3-point fixation from the standard nail as well as the fin nail, and I think that gives a lot of stability to it.
Is there any difficulty in deciding the length of the nail, particular femur, when there is no anterior curvature there with the nail?
No, but we strongly believe that in the distal third, we should use retrograde approach because there's not as much femoral canal bone support. So we have not had a problem with that. And yeah.
Dr. Zirkle, what are your thoughts on fin on both the sides?
What?
What are your thoughts on fin on both the sides without locking?
I don't think we could do that because how would you put it in? And I do think we need some screw in the nail. I do think we need the interlocking screws.
Okay, Dr. Fasi from the Pakistan has said the technique of using the fin nail. He says that the technique of the fin nail is that we don't ream the fin area, and there are markings on the reamer how much to ream, and not ream for the fin area. Is it true?
Yes. You ream down for the shaft, and then the fin is wider than the shaft. So your last ream only goes to the beginning of the fin.
Okay. So you have to be very accurate in reaming length also, and the nail length. Both has to correspond very well, so that you do not ream where the fixation is going to happen by hammering itself by interference fit.
Yes.
If you ask me, there's never hammering of the sign nail. It's just a movement with the hand.
No. He says that they are hammering it.
Yes, tap.
Some of the faculty said that they have to hammer the fin nail, and then they get that final fixation after hammering. And that's why many times hammered in, it is a hammered back is a difficulty with the fin nail. I think so. That was the observation, Dr. Antao, sir.
No, naturally the fin is to keep a rotational stability. So how can you rotate and pass the nail?
Yeah, you cannot
won't
pass
actually
it.
be rotation.
If it is a rotationable, then it is not fixable.
Yes,
then it's not fixable. So it's just like a K nail. You are getting interference fit. In the K nail, it is with a slit. So it expands in the canal, and then it goes like down that. And so that gets the fixation. Even the straight nail, K nail gives the fixation in the curved canal. That was the same interference fit principle.
I have one practical question.
Is the fin. It is called, the difference is the fin because it engages better than the K nail, it holds.
I have a practical question that Dr. Zirkle, what is the cost of this nail? Because we are getting our interlocking nail at $50 in my institute. So what exactly is the cost?
Not, it is less than $50, sir.
4,000 rupee.
No, it is less than. It is less than. All interlock nails are at 1,500 or 1,700 or 2,000. Discounted price. When you are ordering in the bulk.
Bulk, yes. So what is the cost there?
The cost for us to make the nail is $80. The cost for the whole thing is about $150 when you include amortization of the instruments and the reamers.
Okay. It's a great thing. You're giving us free.
Go for the next presentation.
Yeah. Yes, yes. You can go for the next presentation. Dawal bhai, are you there?
What does everybody say? You want to continue?
Okay.
I'll go.
Maybe Nicholas, maybe you take one case and summarize everything that's been discussed today. I mean, another 4 or 5 cases might be little.
No,
instead of that, I think you heard everybody. So I was just thinking whether you can summarize the whole philosophy with your open femur case or something like that. Because you heard a lot of people, I think that would be very interesting to, a broad spectrum of the, the philosophy of the implant, the technology, the principles, and its wide applicability. Because you in India is the only one who has got a wide experience. I think.
So I will just show.
I got a feedback from the Kolkata that from Kolkata, many people have used more than 150 or 200 nails there when Dr. Zirkle visited in India, Kolkata, I think.
Dr. Mukherjee is there.
Dr. Mukherjee, yeah, Dr. Mukherjee. I got a feedback just now that they are also using. We were not knowing, otherwise we have included him also here because we do not have that database. Yeah.
The other thing is the solid nails as a solid versus hollow nails as a concept. I think that itself is a big database in the sign that is there a big advantage of the solid nails as a fixation. So even if it's 8, the 8 looks still stronger than a 8 mm hollow nail, So I think that's a very interesting.
If you know, mechanically hollow nails are more stronger than the solid nails.
No. I said
that's interesting.
In those cases, if you ream up to 15, 16,
stiffness of the stiffness of the sign nail is 49% more than the hollow nail, and the bending forces are 149% more.
Sir, ultimate tensile strength will be same in the both. If you make a hollow because here you are using mostly 8 mm nails in a short statured patients in some of the countries like Vietnam. So 8 mm, if you make a 4 mm hole, then it becomes only 2 mm wall. So I think that must be the concept why they have kept it a solid nail.
No, we are using in femur 10 usually, and then 11 up to 12 we are using.
Yeah.
And in tibia, mostly.
But there you ream it, ne? There you ream it.
Yes,
in tibia,
of course.
You are not reaming,
we of course ream most of the time.
Most of the time, what we heard from the Vietnam is their experience is no reaming at all in the tibia in 8 or 9.
Nowadays we are, of course, we are
reaming.
Sorry,
actually, in Vietnam for the tibia. In most of the case, we don't need to reaming it. We use the 8 mm nail.
Okay.
But in some case, in some big patients, and we need to use the lateral nail. So we need to reaming, but less common compared to the non-reaming for the tibia. Yeah.
Navin bhai, can I just run through the presentation?
Yes, go ahead. Dr. GSK sir wants to say something. He has raised the finger. Yeah.
See, the strength of the nail is counted by the diameter raised to 4. And if you take a solid nail, you have to include all the whole diameter. But if you take a hollow nail, the strength diminishes by a fourth of the diameter of the hollowness. So, but there is not much of a difference because the hole inside is hardly 3 to 4 millimeters. So even if it is 4 times, and if you take the 10 millimeter, the 4 times, the difference between the two is not much.
In a small standards in the primary, I was hearing a story from the school teacher that Galileo compared it in the jail, the hollow tube and a solid tube, a difference between two.
No, that's wrong.
Oh.
No, there is a clarity. Let me tell you, there is a clarity. The amount of metal which you have used for a solid nail, if the same amount of metal you use for a hollow nail, then naturally hollow nail is wider, and that is why you get a better stability. It is the amount of metal which is same in both the nails and not the diameter. That is how the science Galileo has explained.
No, sorry to disagree with you. I will show you the
I don't think there is no much difference between two. There is
yeah,
no much
that's right.
Yes.
That's right.
But it becomes very easy. If it is a cannulated, it becomes very easy to pass a guide pin, and on a guide pin you can pass it.
Absolutely.
Or even interlock, during interlock you can do tick, 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 and you can see the screws whether your guide pin has reached to sounding technique.
There is a definite advantage of using a hollow nail, but the solid nail is slightly stronger than the hollow nail. This is a fact.
Right.
Another thing is the matter of biofilm. So in the solid nail, there is less chance of
No, sir. Let me explain to you again. When you talk about the physics, I am not talking about the same diameter of both the nails. I am talking about when the same metal is used to manufacture hollow nail, naturally hollow nail is going to be wider because you have more metal. So the thing is different, which I want to explain to you.
But we have to compare
we have to compare
same diameter nails.
No, that is true in orthopedics.
We are comparing the same diameter nail.
I agree. That is in orthopedics.
Hollow diameter, hollow nail, and the same diameter solid nail.
There I completely agree. But Galileo has described about the amount of metal, and that's why they say that if you want to create a good structure, you make a wider one and make a hollow one.
In that case, the diameter of your hollow nail is more than the diameter of the
yes.
That I agree. That I fully agree.
Okay. Go ahead. Share the screen in the middle. Yeah. We can see it. We can see it. Your case number 9. Yeah.
Case of segmental compound fracture in the mid.
सर आपके घर से बैकग्राउंड में कोई के घर से फीमेल वही जा रहा है.
Not mine.
Okay.
Fracture again. We did here when there's a comminuted fracture, when you do the retrograde, there's always collapse, and that's why what we add a plate, and that's a function. You have an intra-articular fracture like this.
So you added the plate on the nail.
Yes.
Okay.
Okay. Now this is an intra-articular fracture. You would like to do maybe a locking plate, but I have done reduction and nail. And that is the function.
Okay.
This is a segmental fracture, crash injury, polytrauma. A big-time swimming coach was run over by a truck, and he had multiple fractures, open fractures. You can see the amount. He came after 12 hours after midnight, and from midnight to wee hours of the morning, I had to sit down and debride the wound, and then put him on fixator, remove all the dead tissue. Later on, do bilateral retrograde nailing and tibia nailing also, and that's the rehab with massive skin grafting. Believe me, there was no other tissue left on his body to do the skin grafting.
Okay.
And that's back to swimming.
Good job.
Very good.
So, Nicholas, you think the solid nail helped in this case?
Huh?
You think the solid nail helped in preventing infection in this case?
All right. We were talking about malalignment and all. I found this study where there's a true rotational deformity of more than 15 degrees in 33% of the cases, independent of location, fracture type, implant design, or metallurgy. The external rotation, internal rotation, they are equally found. And this is done with CT scan, not with eye. And this study is from India. Yogesh Sharma from the Department of Orthopaedics, Arm Medical College, Pune. All right. Now, this is interesting case. 65-year-old retired male came with compound grade 3B, comminuted fracture with intra-articular extension. He was operated multiple times in Hyderabad. The details are not known. He presented to me with frank non-union like this. There is a CT scan. What will you do? Any advice?
Is there any infection?
No infection. The parameters were all right. But although when I opened it up, I did send the tissue for leukocyte and tissue culture and all. But I was lucky that I did not get any signs of infection. Anything, sir?
Yes.
Go for angle blade plate. We can go for angle blade plate. In such a case that it is the only implant which can hold very well intercondylar region.
All right. Okay. Anybody else?
No, sir. Just you finish up, then and then we'll discuss. Okay. I think
this is the thing. You can see it inside, and this is what I did. Thin nail with 2 plates, ordinary flimsy plates, but lot of bone grafts and composite bone graft too. Allograft with composite bone graft and also Tata bone graft. And you can see the function. He was not working for 5 years. And this is anyway, he is walking.
It's a diamond case.
All right. This is a case of osteoarthritis with supracondylar fracture. Would you like to do only, what would you like to do? Plate fixation, nail. All right. I did nail plus TKR at the same time. And that's the function at the end of 3 months.
Good, good, very good.
Okay, this is another area where we have explored into using sign nail, using arthroscopy assisted fixation, and see, you can see the sutures. The clips are still there in the old lady. She is comfortable sitting 90 degrees. When you do a arthroscopic assisted nailing, because it's a keyhole incision that helps you to assess the meniscus, cartilage, ligaments, can visualize the correct point of entry of the nail in the notch. See that the nail is not proud and remove all the debris that result when you are doing the whole point for the entry.
So it is a dry scopy?
Not really.
Okay.
So that proves you are an arthroscopic surgeon.
Yeah. Okay, now I go to thin nail in femur. This is 24-year-old non-union. You can see the plate jutting out here. And you can see the plate jutting out on the X-ray also. He's a toddy tapper, fell from the coconut tree, right-sided person, plate, anterolateral approach. Failed to, patient was presented after 5 years. Plate came out from proximally impinging the skin, causing pain, not using his hand, so he can't go on the coconut tree to get it, so becomes unemployed. So I did sign nailing for him, right? And that was the function at the end. This is another case. You can see this case. Very often you see this because of mobility of the plate on the bone, there is some sort of a expansion of the bone here.
Yes, lysis and expansion, instability, yeah.
So what do? This is what was there inside. Plate, lot of cavitations.
And looks like that is a metal reaction, metallosis.
Yes, yes. That's, you can see it here.
Yeah, metallosis is there.
Massive bone grafting. You can see it here. The nail is slightly jutting out because of the collapse. All right. I made a mistake of not putting a static nail, a screw, but I wanted the fracture to collapse. If I had to put a static screw, it would not have collapsed. And that's the function. Another case, this is a Chaiwala, multiple operations, nailing done, plating done. You can see they broke, kept breaking, and then metal reaction. And then we did the sign nail and beautiful function. Now, 3-step screw can also be used. The screws can also be used situations like this. When you have fracture of the lateral condyle, multiple pieces, He came in the middle of the night with Gaslo 3A, compound fracture, could not afford CT scan at that time. So because it's an open fracture, I went in the night, did the fixation, used SIGN screws, and you can see the beautiful alignment, restoration of the curve, contour of the lateral condyle, and that's a function. This is Pipkin's fracture with PCL fracture, where we had done posterior approach, fix the fragment together, beautiful reduction, function. All right. And SIGN screw had been also used in talus, fracture posterior part of the body and lateral part, where we put the screw and by a posterior approach and a lateral approach, and that's the function. Finally, this is the last case where there's a fracture dislocation, type 2 Mulch classification, not dislocation, anterior-inferior type. You must remember here there is a Hegel, humeral aberration of the glenohumeral capsule. There's a big fragment. There is also a rotator cuff tear. All these, if you don't look and only fix the fracture, then you don't get good results. And it's important to take into consideration when you are fixing the fragments together. All right, this is my last slide. I must thank Dr. Zirkle for welcoming me in the SIGN family in Ahmedabad in 2000. And my long journey of 20 years, I have expressed my here. It was very soul enriching to see the smiles on the suffering patients and heartwarming. Working in a mission hospital, grateful to the innumerable patients who put their confidence and trust in me and gave their life in my hands. I must have committed some errors in this journey. I consider it as a learning process and to decrease my curve and to give the best to the patient next, the one who comes to me. Believe me, I have not changed to any nail except SIGN nail. I have not done any other nail except the PFN. So my last message is give your best and leave the rest to God to handle the rest. Thank you.
Fantastic, fantastic,
Very
fantastic.
good, very good.
And these screws are of differential threads. That's why it is working as a compression screw, I think.
So I have a question to Dr. Zirkle, that since you have found out a very good squat and smile for lower limb fractures, have you thought of anything for the upper limb fractures?
Yes,
something like that?
Abduction and extension range.
Squat and smile is some good thing for a lower limb fractures, but what about the humerus fracture? Anything else?
Yes, we have. We've thought of the flex fracture, but also plank. Do you know plank? Yeah. And we're just starting to do this. And that's the value of our database, is that we can correlate the X-ray with the clinical, as you point out. And I think we need to do that, because the rust score is not accurate according to many different people. So we're trying to find better ways.
Okay, Dr. Zirkle, can you just sum up now your experience, what you have said earlier, and the closing words?
What do you want me to do?
Zirkle sir, closing remark before we close the webinar. Before we close the webinar, see the smile on the Vietnam faculty. He is asking since long that when we are finishing the meeting, sir.
We started in Vietnam, and I'm very grateful to the Vietnamese. I want to say that I'm very grateful to all of you and to all the SIGN family. We're very close. The first fin nail we discovered was with Farouk when we hung up a reamer. The reamer wouldn't go in and it wouldn't go out, and I had a plane to catch, and I was very discouraged. And
So when I got home, I thought, why don't we put a reamer tip at the end of the nail? And that was the beginning of the fin nail. So I want to thank all of you, and it's been a very good conference.
So you got the idea of reamer fixed in the canals, and you took as a, yeah. So you took adversity into an opportunity. Thank you, sir. Thank you. Thanks to all faculty. Thanks to all faculty for accepting our invitation of sharing and
you're a great host. Really.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you very much. Thank you, Dr. Zirkle. Thank you so much.
Hope to meet you in future.
And I make you all meet here virtually to Dr. Zirkle. All family of SIGN nail, SIGN implants have met virtually here during the lockdown.
SIGN family. Actually.
Yeah, SIGN family. Yeah. So just now I am just closing.